And device fine. Now my voice is clear. Am I audible? Hi everyone, good evening. So now it's audible. Yeah, okay, fine. Let me share. Hi everyone, good evening. Audible now? See, now I think it's audible. Please write in chat box. Okay, fine. Yeah, everybody. See, there was a technical problem, so like we have shifted here. Okay, fine. So let's start the clinical marathon. I hope you have you have enjoyed solving 150 questions. Okay, these 150 questions were made out of the non-clinical subjects. Okay, where we have covered anatomy, physiology, biochemistry, micro, pharma, and pathology. Right. So 75 questions are already discussed by Khalil sir. Fine. And next 75 questions we are going to discuss now. Okay, so first question, what is your answer here? See here, a 25-year-old male met with high velocity road traffic accident leading to avulsion injury. Right. So now tell me, during this surgical repair, which of the following organs should be repaired first? See, this question we have already discussed before also like on YouTube Live, but this question is very, very important and a repeatedly asked question. So many people are there. Okay, like so many people are there who still get confused. Okay, which structure should be repaired for the first? See here, after the heavy road traffic accident, when you are working in emergency department and you can see that leg is completely open, you can see the broken Okay, you can see the broken bones and the nerves, arteries, and veins and muscles, everything, right now. So now the question is that when you are going to repair the wound, which structure should be repaired first? Okay, some of you are answering what? Artery, right? Okay, see here. See, like artery, you are thinking because you are thinking that first of all, you have to stop the bleeding, right? So that's why you are thinking artery. Okay, fine. Okay, some of you are thinking, okay, nerves, right? Okay, fine. See here. Okay, but most of you are marking artery. Why artery? Because you want to stop the bleeding first, right? Artery can also be blocked. Artery can also be blocked with the help of a clamp, right? Now, artery forceps clamp, you can stop the bleeding. Yeah, please understand that. Suppose if you are going to repair artery first, after that vein and then nerve, and at last, if you want to repair bone, see, whenever there will be open fracture, okay, bone fracture is like this. So now, okay, so don't you think like there will be spikes over the bone? There will be spikes over the bone ends, right now. So even if you have repaired arteries or some other structure because of the broken bone, see, there can be injury of those structures again, right now. Fine. Most important thing is that most important thing in the management of this patient, first of all, suppose if there was the bone like this, right? If there was a bone like this, right? Okay, first of all, you have to maintain the alignment. Suppose if there was the fracture, like this, first of all, you have to maintain the alignment, fix the bone first, and along the alignment, you have to repair arteries and some other structure. So always remember, whenever you are going to get this kind of case, first of all, you have to repair the hard parts first. Okay, so first of all, bones first. Always remember, first bones, and after that, second hard will be what? Okay, that will be tendons, right? Okay, fine. So here in this question, your answer will be what? Your answer will be bone. First, you are going to repair bone. Okay, see the sequence here. First of all, you have to repair and fix the bone. You have to fix the alignment, and as per the alignment, you are going to repair other structure. After that, you are going to repair the tendon. So first of all, extensor and then flexor tendon. After that, you are going to repair arteries and then nerves and vein. See, vein can be repaired afterwards also, because see, like if you have to compare artery and veins, which should be repaired first? Please understand that in artery, there will be high pressure. So there will be severe bleeding from the artery, right? No, severe bleeding. Yeah, but if you see the veins, right? So veins, like from veins, there will be what? Sluggish blood flow, right? Sluggish blood flow. At last, you are going to fix with skin coverage, right now. So this is easy question, but repeatedly asked question, and this is a type of slippery question for so many medicos. First structure to be repaired is always bone in this kind of patients, right? Okay, next. See here, a mother, she comes with her 3-year-old baby. She complains that her baby has swallowed a coin. What is the most common location of obstruction you suspect in this case? So what is your answer, please? Right. Very good. See, like this is repeatedly asked question in MCI, NEET, PG, everywhere. Okay, see here, first of all, now you tell me, see if I ask you one question. See, if I ask you one question, what is the narrowest part of GIT? What is the narrowest part of GIT? What is your answer? See, if I ask you, what is the narrowest part of GIT? Answer me, please. Okay, yes, very good, very good. See here. See, when I talk about esophagus, yes, very good. When I talk about esophagus, right? No, esophagus. And after that, you are going to see a stomach. See here, when I talk about beginning of esophagus, this is the narrowest part of esophagus also, and this is the narrowest part of GIT also. Here you are going to see which muscle at the beginning part. You are going to say this muscle, 𝗵𝗺pharyngeal muscle. Okay, fine. So this is the narrowest part. So whenever a baby is going to swallow any coin or battery, first place where you can suspect that there can be obstruction, that is what? Like at the beginning of the esophagus. Okay, fine. So here, see in this question, like easily you can tell the most common location of obstruction you suspect at the beginning part of esophagus. So basically I am solving the clinical anatomy question here, right now. Okay, the clinical anatomy question here. So, okay, related to anatomy, now you tell me. So related to anatomy, now you tell me how many narrowing part, see how many like narrowing are there like in the esophagus. Okay, fine. Chalo, okay, we can, the basic anatomy we can solve, and with the help of basic anatomy, we can solve so many clinical questions. See here, when I talk about this part, first of all, like there will be a first narrowing here at the beginning, and after that here, and after that here. First at 15 centimeter. Okay, first at 15 centimeter from upper incisor. When we are going to measure from upper incisor, first narrowing in the esophagus, you are going to see at the 15 centimeter. After that, at the 25 centimeter, and at last there will be 40 centimeter. Fine. So this is actually the beginning, right? Now this is actually beginning part. Okay, fine. And after that, see here, arc of aorta. See, arch of aorta. Arc of aorta. At last, at 40 centimeter from upper incisor here, yeah, at the diaphragm, yeah. But if you have to measure, like if you have to measure one more part, like that will be at here, at the 27.5 centimeter here, left bronchus. So actually the mnemonic is BALD, beginning of esophagus here. After that, arch of aorta at 25 centimeter from upper central incisor, and after that at the 27.5 here, left bronchus, and D for diaphragm at 40 centimeter. Right? Easy to understand? Chalo, very good. Very good. So see, this is about the narrowing in the esophagus. Okay, second question. See here. Okay, now do understand what kind of questions actually examiners can frame. See, suppose if a general surgeon is framing this question, he will be asking what is the first line of management, right? The first line of management. So now you tell me, if I ask you the same question, same clinical condition, you are having the same patient, but I'm asking you, what is the first line of management? What kind of investigation you are going to do here? Yes, first of all, you have to take the, see, first line of management, please answer me. First of all, you have to take the X-ray of neck. X-ray of neck. X-ray of neck. Second question, if I ask you, what should be the direction, what should be the view of X-ray of neck? Are you going to take only in the anterior-posterior view, or you are going to take also in the lateral view or in the oblique view? Okay, fine. So first of all, see, first line of management, you have to take what? X-ray of neck. But whenever there will be long structure like this, no, whenever there will be a long bone also, see, a long bone fracture also, please understand that you have to take the view in two directions, AP and lateral. AP and lateral. AP and lateral. So first line of management is what? First line of investigation is what? X-ray of neck. In which direction? Antero-posterior view and lateral view. Okay, fine. After that, yes, if there is some obstruction, for sure, you are going to remove it with the help of endoscope. All right. Now, if a radiologist, okay, suppose if a radiologist is the examiner, if he is going to frame the question, fine. No. Now he will give you this image, and after that he will ask you, obstruction is in esophagus, food pipe, or airway. Answer me, please. See, now suppose if a radiologist is there, if he is framing this question, he will give you this X-ray, right? He will give you this X-ray and he will ask you, now you tell me, where is the obstruction? Obstruction is in the esophagus or in the airway? Batao. Answer me, please. How to solve this question? This is a repeatedly asked question. Last time also this was the question, right? No, last time also this was the question. Please answer me. Okay, fine. Okay, very good. Dr. Detective Story Active. Okay, this is your name here. Chalo, fine. Okay. Acha, I can see your answer here. Right. Okay. So how to solve this question? Because this is repeatedly asked question, and I'm sure your faculty might have taught you for sure. है ना? मतलब पक्का पढ़ाया गया होगा question. See, always understand that how to understand whether obstruction is in the esophagus, like in the esophagus or in the airway. Okay. See here, first of all, you have to take X-ray. So when I am taking antero-posterior view, and if I can see round structure there or circular, round or circular, it means this is esophagus. Esophagus. But when I see like in a sagittal plane, or you can see like a slit, and a sagittal plane, or you can say like a slit or oval part, and oval like this. In the antero-posterior view, if it is in a sagittal plane or like a slit, so this is what? Airway obstruction. Airway obstruction. Now, okay, now do understand how to remember this part here. See here, like suppose if a baby has swallowed a coin. See, now you tell me, out of esophagus and airway, which one is expandable? Esophagus is actually a muscular structure, right? A muscular structure. So this is expandable right now. So what is happening here? See, easily whenever a coin is going inside, this will be going in this manner like this. Okay, no? See here, like this. So whenever you are going to see like in a circular manner like this, in a circular manner, antero-posterior manner, this will go in a circular manner like this, right? Okay, so you will see like this. So, okay, fine. After that, to confirm it, okay, when you are going to take the lateral view, this will be appearing only slit like this, right? No, slit or like in a sagittal plane. So this is about esophagus. But when I talk about, airway, right? When I talk about airway, so airway is actually a narrow. So like there will be the entry like this, like in a sagittal plane in anterior view. Fine, easy to understand. Okay, so let's solve this question here, please. See here, whenever we are going to take the antero-posterior view, right now, antero-posterior view, round, okay, no? And sagittal plane, or you can say what? Or like slit. So this is esophagus, and this is airway, and this is what? Airway. Yeah, when we are going to take the lateral view, see, like in the lateral view, this will be opposite. In the lateral view, if you are going to see a round, this is airway. Or if you are going to say slit, like, okay, so this will be what? Esophagus. Easy to understand, very, very important thing, repeatedly asked question. Fine. So how to help the patient? Yes, with the help of endoscope, you are going to remove it. Next question, please. A patient complains of having flushing and sweating over the cheek after eating. He has history of surgery of the parotid gland few days before. Injury of which of the following nerves can be associated with this condition? Very important clinical question, and easily you can solve this question. Answer me, please. Okay, fine. Easy question to solve it. See, earlier they used to ask, like, okay, fine. Dr. Rajiv Yumdam is, as we can see, black line. Okay, chalo, theek, I will explain that part like one more time. See here. Okay, one more thing you can see here, like in this X-ray, one more thing you can see here. Okay, chalo, I will give you more explanation, don't worry. See here. Like this is the location of the coin, right? Now, this is the location of the coin, and this is the vertebral column, right? This is the vertebral column. So which part is anterior? Airway is anterior, and posterior to airway, you have esophagus. See here, when you see this black road, you can see anteriorly, you can see black where you can see air, right? Now, so this part, see this part, right? Now, this black, this is actually airway. This is actually airway. Near to vertebral column or posterior to airway, you will be having what? Esophagus. Esophagus. Right now? So now I'm sure this is clear to all of you. Okay, fine. Next question, please. Okay, see here. A patient complains of having flushing and sweating. So this is the question of, see, this is the question related to, Fraze syndrome. Right? This is related to Fraze syndrome. Fraze syndrome. See, please, what is happening here in the Fraze syndrome? See, yeah, okay, answer me, please. See, whenever there will be surgery over the parotid gland, okay, which is innervated by a nerve that is called as auriculotemporal nerve. Auriculotemporal nerve. Auriculotemporal nerve. Fine. And this is the branch of the mandibular nerve. Okay, now this is the branch of the mandibular nerve, right? Okay, fine. So which is actually the branch of fifth nerve. Okay, fine. See here, around the parotid gland, see, like, which is being innervated by auriculotemporal nerve. So during the surgery, if there will be the damage, and after that, what is happening here? After there, see the branches of the auriculotemporal nerve. This is going to reattach with the sweat glands, right? And this is going to attach with the salivary glands, nearby salivary glands, right now. So when after that, when a person is going to eat anything, he will be having what? See, after that, he will be having what? Okay, fine. And so what is happening is, see, just after, so whenever there will be injury over the parotid gland, and after that, see the nerves, auriculotemporal nerve, which were there, okay, which innervated the gland, now it is going to reattach with the sweat glands. Fine. So whenever a person is going to eat anything, after that, he will be having sweating over the affected part. So this is because of what? This is because of auriculotemporal nerve. So what is the name of this syndrome? This is called as Fraze syndrome. This is called as Fraze syndrome, right? Fraze syndrome. Earlier, they used to ask this question like in one-liner way, right? No, which nerve injury is seen in Fraze syndrome? But now they are framing this question in a clinical manner, right? No, so after the surgery over the parotid gland, now patient is complaining that, sir, whenever I'm eating, I'm having sweating over my cheeks, right? No, so this is what Fraze syndrome, auriculotemporal nerve injury. Next. Okay, see this question. While doing thoracocentesis, it is advisable to introduce needle along. So basically, whenever you will be having a patient of the pneumothorax, or means whenever you have to do the pleural tap, right now, whenever you have to do the pleural tap. Right now, okay, whenever you are supposed to insert the needle in the intercostal space, and after that you want to remove the air or water accumulation there. So now the question is that, see here, this is the rib, first rib, second rib, and this is the third rib, and this is the fourth rib. Now the question is that needle insertion should be done at the upper border of the rib or lower border of the rib, right? See here, needle insertion should be done at the upper border of the rib or the lower border of the rib. I hope you know the basic anatomy here. Please understand that basic anatomy is that neurovascular bundles are located at the lower border of the rib here, right now, at the lower border of the rib. So if you are going to insert the needle at the lower border of the rib, you can damage neurovascular bundle. So during the pleural tap, during the thoracocentesis, what is happening here? You have to insert the needle at upper border of rib, But if I ask you, if you have to do intercostal block where you want to inject local anesthesia so that you can perform the procedure, now you have to block the nerve. So now you tell me, now you are going to insert the needle for intercostal block at upper border of rib or lower border of rib. For intercostal block, you have to insert at lower border of the rib. Lower border of the rib at a certain angle, because the nerves will be lying at the downmost part. Easy to understand? Fine. Very good. Very good. Okay, next question, please. Clinician wants to auscultate which valve? So this question we have discussed so many times, but so many new students are there. And this question, last time this was asked. So we need to discuss this question. Please answer me. See here. Now MCI people, they're asking some question related to your clinical practice, related to your internship. How much basic clinical knowledge you have? So now you tell me, as per the location, see here, no? At which place clinician is keeping his steth? So basically, whenever you are going to do the auscultation of heart, right now, so you are going to auscultate over the valves. There only you are going to hear some sounds right now. Okay, fine. I will demonstrate you. Okay, fine. I'm going to demonstrate here. See, now you tell me here, like suppose if we are, okay, this is the diaphragm part and this is the bell right now. So now I'm asking you, at which point I should keep my diaphragm here, right? Here, here, or anywhere you are going to place. No. See, hard sounds you are going to listen exactly at the location of the valves. So we have to understand the basic anatomy of the 4 valves which I have given you here, right? So where is the location of mitral valve? Where is the location of the pulmonary valve, aortic, and the tricuspid valve? Very easy to understand. You can easily remember it. Okay, see. Yes, very good. Dr. Neha, Dr. Rajiv, Dr. Shubham, Dr. Krishna. All of you are doing very great. Very good. Very good. Chalo, theek hai, nice. Okay, see here. Okay, see, first of all, all of you, you touch your right clavicle. Okay, right clavicle. Please, you touch your right clavicle, you palpate it. Okay, fine. Okay, see, whenever you are going to touch the right clavicle, see, just behind the right clavicle, you are having first rib. After that, you go somewhat down, right? You go somewhat down. So there you are going to have the first intercostal space. After that, you go somewhat more down. There you are going to have the second rib. And after that, second intercostal space. Okay, fine. See this part where I'm going to wear the tie. Exactly at the right border of sternum in second intercostal space. Right second intercostal space. You are having what? Aortic valve. Aortic valve. Okay, fine. Right side, second intercostal space, aortic valve. Okay, now you go towards left, second intercostal space, left border of sternum. You are having the pulmonary valve. Okay, see at this side in the second intercostal space, you are having pulmonary valve. Now you go more down, fourth intercostal space here, fourth intercostal space right now. Fourth intercostal space at the left border of a sternum. You are having which valve? At the fourth border, fourth intercostal space, you are having 𝗲𝗃𝗃 valve. Now, left side, see at the mid-clavicular line, you go in the fifth intercostal space. Fifth intercostal space, right now. So like ideally it is said that just above the nipple. Mid-clavicular line, fifth intercostal space, you are having mitral valve. See here. Right side, second intercostal space, you are having what? Aortic valve. Left side, second intercostal space, you are having what? You are having the pulmonary valve. Fourth intercostal space, fourth intercostal space. At the left border, see this is left border, left border. Fine. Like here you are having which valve? You have 𝗲𝗃𝗃 valve. Mid-clavicular line, left side, mid-clavicular line, fifth intercostal space, you are having mitral valve. So now you see this photo and now you tell me at which location, see where, at which valve clinician is keeping his stethoscope. Now, this is 100% clear. This is what? Which valve? This is option number D. Option number D. Fine. Easy to understand? So now please answer with me. See right intercostal space. Right second intercostal space. Which valve? Aortic valve. Left second intercostal space. Which valve? Okay, pulmonary valve. Okay. Fourth, left intercostal space at the left border of sternum. Which valve? 𝗲𝗃𝗃 valve. Mid-clavicular line, fifth intercostal space. Which valve? Mitral valve. In December, this was the question. So please understand that like this is very, very important topic to understand. Fine. So this is called a what? Auscultation of heart. Auscultation of heart. Fine. Okay. See, as per the location, you can easily understand. Okay, now you see this one. See what this clinician is doing. He is keeping his keeping the diaphragm of his stent over the eye of a person. So like he is doing right, or this is the effect of online MBBS? He is doing right, or he is not a knowledgeable doctor? Answer me, this is right or wrong. So basically I'm asking you, auscultation can be done over eyeball also, here also. Auscultation can be done over the head also. Answer me please. Right or wrong? This is right. Right. This is called as orbital auscultation. This is called as orbital auscultation. Orbital auscultation. You can hear the brutes over, see, you can hear the brutes over closed eyelid, over closed eyelid, closed eyelid. Right now, closed eyelid. Yeah, so in which condition you can see all this? You can see either in the case of the Graves' ophthalmopathy and a Graves' ophthalmopathy, and even you can see in the case of the thyrotoxicosis, right? Fine. Even in the case of the thyrotoxicosis. Okay, now fine. So please understand that brute over eyeball. So brit over closed eyelid. This is called as Reisman signs. Reisman sign. Reisman sign can be seen in Graves' ophthalmopathy as well as in the case of the thyrotoxicosis. See here, when they can ask this kind of question that how to place, how to fix Ryle's tube or Foley's catheter, they can also ask you one question. How to wear a stethoscope? See, like this is what? So these are called a what? Earpieces, no? Earpieces, right? And this is called the steth. This is called the tube. No, this is tube. And this is called as what? So this part is called the diaphragm and this part is called the bell. Whenever you have to auscultate the heart, high-pitched sound here you can keep. Okay, high-pitched sound you can hear with the help of the diaphragm, but low-pitched sound like abdominal brute and all, fine, abdominal aneurysm. Okay, so low-pitched sound you can help. You can hear with the help of the bell. Now the question is that, okay, so now the question is that whenever you are going to wear the steth, no, whenever you are going to wear the steth, so see here, see, like this is, see. So earpieces, no, earpieces. What is the right way of wearing a stethoscope? This earpieces should be going, answer करो बताओ. एक ऑप्शन है, देखो ऑप्शन नंबर ए, towards the nose or away from the nose. What is your answer? Away from the nose. Earpieces should be placed towards the nose or away from the nose. Answer me, please. Always remember that earpieces, no, earpieces of a stethoscope, it should always be placed along the direction of ear canal, ear canal, ear canal. Fine, no? Always be placed at the direction of ear canal. So what will be the answer here, A or B? So it should be towards the nose or away from the nose. Answer is towards the nose. So this can be the basic clinical question in your MCI. Okay, I'm sure all of you know this. Okay, chalo, fine. Next question. A person has been diagnosed by upper respiratory tract infection, basically what? URTI. So I'm talking about URTI and LRTI, right? LRTI, upper respiratory tract infection or lower respiratory tract infection. So out of these four options, which of the following structure may not be involved in upper respiratory tract infection? As per the basic anatomy, of airway, right? You can answer this question. Batao, A, B, C, D. Any infection up to the larynx, this will be considered as up to the larynx, upper respiratory tract infection. Up to the larynx, right? Below larynx, fine. Lower respiratory tract infection. Upper respiratory tract infection. After that, there will be what? Lower respiratory tract infection. So answer is C here. Very good. Now, if I ask you, suppose if a person is having emphysema, right? No, emphysema, or if a person is having, suppose if a person is suffering from the bronchitis or the bronchiectasis. So like emphysema and the bronchitis and the bronchiectasis, these are going to be the diseases of, upper respiratory tract or lower respiratory tract? Lower respiratory tract. Easy to understand now? Fine. Chalo, very good. Very good. Next question. After the dissection of gallbladder from a patient of gallstone, gallbladder is sent to histopathology lab. Histopatho lab. On histological studies, epithelium was found to be tall columnar epithelium. What is the interpretation? Similar question was asked in AIMS, and you can suspect this kind of question in MCI because this is the basic clinical question of histology, right? I hope you remember the type of epithelium in gallbladder. The type of epithelium, see the normal epithelium in gallbladder is what? Okay, this is the tall columnar epithelium, right? This is the tall, this is the tall columnar. So when it is 100% like this only, so it means what? This is a normal gallbladder. This is a normal gallbladder. Do understand that whenever we are going to operate any patient for the gallbladder stone, after that we have to send the gallbladder to histopath lab. Why? Because we always suspect that. See, we should understand that is there any risk of development of the, is there any risk of what? Yeah, is there any risk of the development of the gallbladder carcinoma? Right now, fine. And why this is important? Okay, please write few points related to surgery. If anyone, if a person who is having gallbladder stone, a patient of gallbladder stone is having the risk of development of carcinoma of gallbladder, how much? 0.323%. 0.323%. But if a person who is already having gallbladder carcinoma, how much association is there of carcinoma with the stone? This is approximately 75 to 98%. So what does it mean? Gallbladder carcinoma is extremely associated with stone. So do remember this part. Again, so after the surgery, so after the removal of the gallbladder, this is really very, very important to send gallbladder to histopath lab for the further investigation. Fine. So for the further examination. So what is happening here? So when there will be epithelium like the tall and the columnar epithelium, but if you can see metaplastic epithelium, if you can see metaplastic epithelium over the gallbladder, like gastric and intestinal, If these kind of epithelium will be there, okay, metaplastic epithelium over the gallbladder, then yes, patient is having the development of gallbladder carcinoma. Easy to understand. Now next, see, what about option number D? Do you think option number D is important? Okay, this is worth of discussion. See, what is the other name of option number D? What is the other name of this part? Cholesterolosis. Repeatedly asked question. If they are going to ask you, suppose, see, like they can ask you one-liner question, they can ask you image-based question out of this topic. What is the meaning of this word? Which type of pathology is this? See, whenever there will be deposition of lipids, whenever there will be deposition of the lipids and the esters in the mucosa of gallbladder, after that, what is happening is, see the picture here, you will be having more clarity. See here, when you do examination, when you see this kind of yellow lipids, right? No, lipids fine, but what about the background? You can see there like red hemorrhages, right? No, see, because of the hemorrhages there, you can see the background as red. This appears to be what? This appears to be strawberry, right? So this is also called as strawberry gallbladder. Repeatedly asked question. If they are going to ask you one-liner question, okay, which of the following is known as a strawberry gallbladder? Answer will be what? Cholesterolosis. Whenever there will be accumulation of deposition of lipids and the esters in the mucosa of gallbladder. Easy to understand. I hope this is clear to you. See these two pictures, very, very important. This can be your image-based question. This is called as strawberry gallbladder. Next question, please. A patient presents to the emergency department with severe complaint of pain going down the leg from the lower back. She has the history of intramuscular injection at the gluteal region by an inexperienced healthcare worker. Which nerve is mostly involved in this case? Yeah, this is related to, see here, I'm discussing clinical anatomy. But See, after learning clinical anatomy, we have learned how to give intramuscular injection over the gluteal region, right now. So now you tell me, suppose if this is the right buttock, right now, suppose if this is the right buttock, okay, fine. Okay, right gluteal region. So see, now you tell me upper quadrant, right? Upper quadrant. See, this is like if you are going to see it from the back side, right? From the back side. So this is the right upper quadrant, and this is actually what? Upper quadrant, but this will be moving towards the left side, right? Okay, fine. And this is the, okay, this is lower quadrant. Okay. Now you tell me, out of 1, 2, 3, 4, which is the safest site, gluteal site for the intramuscular injection? Safest site is upper outer quadrant, right? 1, 2, 3, 4, which one? Upper outer quadrant, right? Upper outer quadrant, this one. Okay, now, so this is the safest site for intramuscular injection in the gluteal region, right? Upper quadrant. Okay, now? Outer, you can say what? Outer upper quadrant. Okay, fine. So now, yeah, okay, fine. See, why not in the upper quadrant but this side? Because here you are going to have what? Insertion of a nerve, very, very important nerve. See, like the dimple at the backside, from where? Okay, from there will be origin of one important nerve, that is called as sciatic nerve. That is called as sciatic nerve. If an inexperienced clinician or healthcare worker is going to inject more medially, upper quadrant, but more medially, right now, he can injure sciatic nerve. After that, patient will be having severe pain, as I have given you in this clinical condition. This is called as what? Sciatica. Sciatica. So which nerve injury actually? Sciatic nerve. Okay, fine. Now the question is, okay, fine. Now let's discuss some more points related to your anatomy. Now you tell me, which is the safest muscle to give injection? Gluteus maximus or gluteus medius? Answer me, please. Gluteus maximus or gluteus medius? What is the answer? Yes, answer is what? Gluteus medius is safe. Right now, gluteus medius. Safe is gluteus medius. See here. Safe is gluteus medius. Gluteus medius. Since we are learning about what? Injection, so we have to learn so many things here. Don't worry. So I will teach you like so many clinical part here. Okay, now how do we practice in hospital? I'm going to teach you everything here. Okay, so gluteus medius is safe. I say this much part is going to be covered here, right now. Gluteus medius. Fine, gluteus medius. See, but suppose, okay, what is the alternative way? Right now, what is the alternative place? Fine. So next will be what? Lateral aspect of the thigh, where you can inject in the vastus lateralis also. Apart from gluteal region here, see, apart from the gluteus medius, you can inject in vastalis lateralis also. Okay, lateral aspect of the thigh. Now, some more points related to injection. See here. See, whenever we are going to give intramuscular injection, this should be straight, right? Okay, fine. See, this part is muscle. After that, you are going to see subcutaneous, then there will be a dermis, then there will be epidermis. So with the help of basic anatomy, we are going to learn different type of injection. See, there can be intramuscular injection, subcutaneous, intravenous, and then intradermal. Fine. See, straight, whenever we have to give injection, okay, see, whenever we have to give injection directly into the muscle, that is what? Intramuscular injection. So whenever we are going to give the injection, or whenever we are going to insert the needle, okay, first of all, we are going to pull the syringe like this, and after that, we are going to, after that, suppose if there will be blood in your syringe, it means you are not in the deeper part, you are in the vein, you are in the blood vessel. So, and so you have to be very, very careful. Fine. So now what kind of question they can ask you? Whenever we have to give intramuscular injection, at which angle we should insert the needle? Intramuscular, answer me please. 90 degree, perpendicular. Subcutaneous, 45 degree. 45 degree, right? After that, what about intravenous? Batao, intravenous? Intravenous, approximately 25 degree. Fine. Intradermal, 10 to 15 degree, right? 10 to 15 degree. I hope this is clear to all of you, right? Very good. Now, see, there is one more type of injection. See, there is one more type of injection that is called as Z type of injection. Z-track injection. This is called a what? Z-track injection. Z-track injection. See, now you tell me, whenever I'm going to give intramuscular injection, whenever I'm going to give intramuscular injection like this, an intramuscular injection like this, but whenever I'm going to remove the needle, and whenever I'm going to remove the needle, right now, right? See, whenever we are going to remove the needle, so don't you think like like some medicine or the drugs that can also get accumulated in the subcutaneous or the dermis here? Yes, it can occur. Fine way. And this can happen right now. Okay, fine. But if we have some special drug or the medications are actually what? Irritants. And irritants like iron injection, or you can say the dextran injection, right? Dextran injection and iron injection. See, this is approximately intravenous. This is approximately 25 to 30 degree. Okay, that should be clear. Okay, no issues at all here. Okay, fine. So whenever we have to give injection iron or the dextran, no iron or dextran. See, this is actually what? Irritant type of medicine, irritant type of the drug. So whenever if you are going to give intramuscular injection directly and while removing the needle out, some drug, some iron can get deposited in the subcutaneous also here. Fine. So now after that, there will be a problem for the patient. For now, so there is a special type of injection. What is happening here? First of all, I'm going to pull the skin back like this. See the lateral displacement of skin like this. First of all, I'm going to, agar मान लो है ना कि now you are going to give injection. So first of all, you are going to pull it like this. After that, you are going to give the injection. Right now, first you have to pull the skin. So basically, you can say that first of all, there will be lateral displacement of the skin. After that, you are going to inject like this. Fine. Okay. And after removal of the syringe, you are going to leave it. So what is happening is, so this is something like this. So this is called as Z-track injection or Z-track injection. So because of this, when you are going to pull it and after that you are going to remove like this, what is happening here? See, like in the intramuscular region, like while doing like this, there will be what? See, there will be 100% sealing of the drug. This is going to seal the drug completely in muscle, intramuscular. Okay, no? So this is a type of what? Intramuscular injection. Fine. All right. Easy to understand? Chalo, fine. Next question. After a road traffic accident, a 43-year-old male is brought to emergency room with swelling and severe pain below knee. Doctor is doing peripheral vascular examination to check pulses of which of the following artery. See, very, very important point. Whenever you will get a fracture case, you have to palpate the blood vessels there, right? You have to palpate the artery. Why do you see why this clinician is going to palpate? Why he is palpating this part? Why is palpating an artery there? Why? Because see, if there will be internal fracture, see, if there will be internal fracture, right? See, it could be possible that after the fracture of the bone, say bone can rupture blood vessel also. If bone is going to rupture the artery, then there will be lack of pressure and you will not feel any pulse. It means what? Situation is very, very dangerous. If you can feel the pulse, it means what? Vascular bundles are intact, normal. Okay, fine. Easy to understand. So this is very, very important to palpate the blood vessels. So now you tell me over the dorsum of foot here. So which artery you are going to palpate here? This was the question in December exam, last time, December. Okay. So here you are going to see dorsalis pedis artery. Dorsalis pedis artery. Fine. So why do you check it completely? And so that if there is a pulse, right now, blood vessels are completely intact and the blood circulation is normal. Easy to understand? Fine. So now you tell me if you are going to palpate over the medial side of the ankle. See, like if there will be, see here. So here you are going to palpate. First of all, picture number A. Picture number A. Which blood vessel? Okay, dorsalis pedis artery. Dorsalis pedis artery. But what about here? Picture number B. Picture number B. Batao. Which one? Very good. Posterior tibialis artery. Posterior tibialis artery. Okay, now this is actually what? Posterior tibialis artery. Right? Easy to understand? Very good. Very good. All these can be your picture-based questions also, and this can be related to your clinical practice also. Now, when I ask you, whenever you are going to measure blood pressure, you are going to keep the BP cuff over the elbow, just above the elbow, just above the like cubital fossa, middle cubital fossa, right? So now you tell me, see the pressure of which artery you check here over the elbow. Pressure of which artery? Answer me, please. Whenever you are going to place BP cuff above the medial cubital fossa, okay, no? Or just above the elbow or over the arm. So basically pressure of which artery you check here? Very good. That is actually the brachial artery. Okay, fine. Now you tell me only above the elbow you can check blood pressure or somewhere else also. Okay, fine. Over the wrist also, right? Over the wrist also. So over the wrist, which artery there? Radial artery. Radial artery. But suppose if you have a patient who does not have upper limbs, or he is a patient like the Thakur of Sholay movie, right? Fine. No? Suppose if your patient does not have upper limbs, then where you are going to check the blood pressure? Over the lower limb also, right? Over the lower limb. So you can place the BP cuff over just above the knee. Which artery there? Just above the knee. Okay, there you are going to see the popliteal artery. Over the ankle also, here also you can keep BP cuff. So here you are going to check what? Dorsalis pedis artery and posterior tibialis artery. Easy to understand? See this part here, right? So here, radial, fine. Here, brachial artery. Above the knee, popliteal artery. Above the ankle, dorsalis pedis as well as posterior tibialis artery. Okay, now next question is that which type of incision should be given? Which type of incision should be given while operating on common bile duct? See, this is liver. Okay. See, this is the duodenal part, right? This is the duodenal part. Duodenal part. Yeah, answer me, please. So here you should understand the basic anatomy, the basic blood supply of bile duct, right? No, so basic. Answer me, please. Okay, you are saying B. Okay, longitudinal incision, right? Longitudinal incision. Fine. Okay, see here. Okay, so first of all, we have to understand the blood supply of bile ducts. Okay, biliary tract. Okay, na? Biliary tract. See, please understand that. See, the biliary tract is having solely, actually, if I talk about the perfusion, here you are going to see what? Arterial supply, mostly arterial perfusion. But when I talk about the liver, here you will be having what? Portovenous shunt. Portovenous shunt. So basically, when I talk about the blood supply or the perfusion of biliary tract, so basically arteries are there. See, below the duodenal bulb, there will be what? Infrabile duct, and above that, there will be suprabile duct. Now, the question is that if I ask you which blood vessels are supplying the biliary tract, answer me, please. Answer me, please. See here. When I talk about inferior bile duct, which blood vessels can you answer me? Answer will be this is the posterior superior. This is the posterior superior pancreatico duodenal artery, duodenal, and gastroduodenal artery, and these are located at 3 o'clock and 9 o'clock position. So basically it is going like this. See, basically it is going like this. Artery supply is like this. So now if I ask you, are you going to give incision when you have to operate over a bile duct? Are you going to give incision like this? Or are you going to give incision like this? No, obviously no, because if you are going to give incision like this, you can rupture blood vessels there. So the safest incision will be straight longitudinal. So longitudinal incision should be given. Okay, it should be given when you are going to operate over bile duct. And see CBD stones and all fine. So like there will be situation, there will be circumstances when you will have to operate over bile duct for sure. Fine. So on the basis of basic anatomy, on the basis of blood supply of the biliary tract, we can find out which is the best way of incision at this place. Easy to understand? Fine. Next question here. A 45-year-old male has nausea and vomiting, burning stomach pain, bloating, belching, feeling of fullness, intolerance to fatty food. Okay. Intolerance to fatty food. History of upper GI bleed is also present. As per the endoscopic findings, a surgeon has planned for the surgery. Okay. Dissection of which nerve can help the patient? So basically, up to this point, what I was discussing, the kind of clinical scenario which I have framed for you, this was 100% related to surgery, general surgery. Fine, no? But suddenly I'm asking you dissection of which nerve. So now I'm asking you the clinical question of anatomy. Fine. So now, first of all, you tell me what is the diagnosis here? See, as per the endoscopic finding, as per the clinical condition, yes, patient is suffering from what? Peptic ulcer disease, right? So basically, this is a case of what? Basically, this is a case of the gastric ulcer, right? Now, gastric ulcer. Okay, fine. Now, so now you tell me, see, how many types of gastric ulcer are there? See, like, whenever we are going to talk about the peptic ulcer disease, there are two types. Like one is called the gastric ulcer, second is called the duodenal ulcer. See, if I ask you where you are going to see the more bleeding will be seen in duodenal ulcer, right? Now you tell me, if I have to talk about a gastric ulcer, how many types of gastric ulcers are there? How many types of gastric ulcer? 5 types, right? 5 types. Okay, fine. As per the Johnson classification, right? Johnson classification. I hope you have learned in your surgery department. Like surgery, right now. See, there are 5 types. See, like whenever location of the wound is at lesser curvature, right now, lesser curvature. At the lesser curvature, only one ulcer. This is called the type 1. In type 2, there will be 2 ulcers. Type 2, 2 ulcers. So like this can be gastric. This is the combination of gastric ulcer as well as duodenal ulcer. Type 3, location is at which region? Location is at the pre-pyloric region. At the esophageal junction, type 4. Type 4. And the type 5, this can be located anywhere. So this is related to drugs. Yeah, specifically if I talk about NSAID like Flexon or ibuprofen and all, fine, no? So non-steroidal anti-inflammatory drug, fine, no? So like excess consumption of NSAID can result into development of gastric ulcer. So medicine induced is type 5. Now the question is that, see, now let's revise some topics of the general surgery here. See, now you tell me out of these 5 types, where you are going to see the hypersecretion of hydrochloric acid. Hypersecretion in which type? Hypersecretion of hydrochloric acid will be seen in type 2 and type 3. Type 2 and the type 3. Hyposecretion, or it will be normal in type 1 and type 4. So now you tell me in type 2 and type 3, where you can see hypersecretion of hydrochloric acid, do you think vagus nerve has to play a role? Whenever there will be stimulation of vagus nerve, there will be more secretion of hydrochloric acid. So don't you think if I am going to operate, if I am going to do something, if I'm going to do incision, or if I'm going to do vagotomy, my patient will be having what? Right now, my patient can be relaxed right now. Fine. Okay, fine. See here, at this point, at the junction, there will be, division of the vagus nerve into anterior part and the posterior part. Now you tell me, as per the anatomy, do you remember LARP? Do you remember LARP? Left branch of vagus nerve will supply anterior part of a stomach. Right branch of vagus nerve will supply the posterior part of a stomach. Fine. No? So whenever there will be stimulation of vagus nerve, there will be hypersecretion of hydrochloric acid. What about if I'm going to do vagotomy? If I'm going to do vagotomy, right now, if I'm going to do vagotomy, then there will not be a stimulation, there will not be hypersecretion of hydrochloric acid. So when there is no hypersecretion of hydrochloric acid, my patient will be he will be relaxed, right? He will be in which zone? Easy zone, right now. So overall, in this surgery, where we have to perform vagotomy, fine, no? Vagotomy here. Fine. So out of these 4 options, now you tell me which nerve is being dissected here? Vagus nerve, right? Vagus nerve. But you also have learned in your general surgery that vagus nerve is also having the motor supply to the stomach part, to this part, to the pylorus. But when you are going to perform the vagotomy, there will be a stasis, hypomotility of the pylorus, no? Hypomotility. So whatever the person is going to eat, this will not be going downwards, right now. So after that, you are going to perform after that, you are going to perform one more surgery. Either you are going to perform the gastroduodenostomy and the jejunostomy, right now. Bile-Roth 1 and Bile-Roth 2. Bile-Roth 1 and Bile-Roth 2. So overall, please understand that whenever you will be having a case of the gastric ulcer, Overall, whenever you will be having the case of the gastric ulcer or the peptic ulcer disease, okay, one nerve which you have to dissect, okay, you have to perform what? Vagotomy. So out of these 4 options, what is your answer? Answer is vagus nerve. Next question. A patient presented to casualty with complaints of severe diarrhea, nausea, and vomiting. Okay, now this is the question of microbiology. Okay, no, complaints of severe diarrhea, nausea, and vomiting. He has history of consumption of the contaminated food. Okay. On examination, he looks agitated and BP is 90/64. See, 90/64. So like, is it okay if I say that patient is in shock? Yes, patient is in shock. Okay, fine. He complains that he has profuse diarrhea like a rice water stool. This is the point of, see, rice water stool, right now? Yeah, this is the point of attraction. Now you tell me, I hope all of you might have learned about rice watery stool. Where do you see? What is the diagnosis, please? Where you have seen a rice watery stool? Cholera, right? In the cholera. So what is the causative agent here? Vibrio cholera, right? Now Vibrio, okay, Vibrio cholera. Okay, fine. Now the question is that really, so overall, whenever you are going to get the clinical question, you have to, first of all, you have to diagnose the case. And after that, after the diagnosis, it will become very, very easy for you to understand, okay, which media, what kind of media and all, right now? Fine. So here examiner is asking what here? Which of the following transport media related to transport media question is being framed? See, Stewart's media, Pike's media, 𝗵𝗍's media. These are used for Streptococcus or the Gonococcus. But what about VR media here? VR, Venkat Ramakrishnan medium. Yes, this is the transport medium for what? Vibrio cholera. Answer is C. Answer is C. Please remember the table here. See, for the Streptococcus here, Pike's medium. We are using which medium for the transport here? See here, Streptococcus, we are using Pike's medium. Pike's medium. 𝗵𝗍's and Stewart. 𝗵𝗍's and Stewart. Neisseria. 𝗵𝗍's and Stewart. Why not? Neisseria, right? Neisseria. Please understand this part. Okay. And for the Shigella and Salmonella, right? Like these are also the causative agent for the dysentery, diarrhea, right? Fine. So for them, CB medium or buffered glycerol medium. Do remember repeatedly asked question. If they are going to frame the one-liner question, they will ask the direct question. Venkat Ramakrishnan medium is used as a transport medium for which of the following bacteria, for which of the following microorganisms? Answer will be clear. But if they are going to frame in a different manner, right? But suppose if they are going to frame in a clinical manner. So in this way, they are going to frame the question. First of all, you have to diagnose the case. After that, you have to solve the question. Now, after using endoscope in a patient, gastroenterologist has asked the nurse to sterilize it. Which of the following chemical disinfectants will be used by the nurse to sterilize the endoscopic instrument? Why I'm asking you these questions? Because they want to know your basic clinical knowledge. All these things you will see in all hospitals everywhere. Okay, Dettol, like everyone is seeing the Dettol for sure, right now. So this is just the skin antiseptic, right? Skin antiseptic. What about a sterilium? What about a sterilium? This is what? Hand rub. Hand rub. I hope you have used the spirit in hospital. Spirit use karte ho na? Spirit. Hand rub spirit. Spirit, right? Spirit. So basically, this is what? This is ethyl alcohol. Ethyl alcohol. Ethyl alcohol, right? This is ethyl alcohol. Sterilium is what? Ethyl alcohol. 70% ethyl alcohol will be used in sterilium. So this is what? Hand rub. This is just a spirit. Okay, fine. What about iodine? This povidone. This is actually betadine. Betadine. So where do you use betadine? Whenever you have to do what? Whenever you have to clean the wound, right? Whenever you have to do the dressing, antiseptic dressing, right? No? Antiseptic dressing, you have to use the betadine, right? No? Betadine. Now the question is that, see here how they are going to frame the question. You need to understand that they will give you a clinical scenario that after the road traffic accident, a person is having wound over his foot. Okay, you can see what? Avulsion injury, open injury is there. Are you going to use betadine? Obviously, yes. Whenever there will be dirty wound, for sure. So first of all, you are going to wash with normal saline. First of all, you are going to wash with normal saline, 0.9%, right? Wash it. And after that, you are going to clean it with betadine, right? You are going to clean it with betadine. After that, only you are going to perform what? After that, you are going to apply the dressing. Okay, fine. Now, next question is that, see what I have taught you. Whenever you are going to see the dirty wound here or first time wound, for sure, yes, betadine is mandatory. You have to use the betadine. Okay, fine. But you have operated a patient, you have removed gallbladder, right? Now you have removed gallbladder. Open abdominal surgery, it was open abdominal surgery. Okay, fine. Now after this surgery you applied after that you applied the dressing, right? So now next day also, say afterwards also you will have to do the dressing. You have to remove the dressing, old dressing. You have to see the nature of wound, whether it is like 100% fully dry or is there any pus collection. Fully dry or is there any pus collection? Fine. So now when you have removed old dressing, first of all, you are going to see the wound. Wound is completely dry. Your senior consultant has asked you, see the wound, take a picture, send me on the WhatsApp, and after that, do the dressing as per the requirement. My question is, are you going to clean it again with the betadine? Again with the betadine? Yes or no? After a few days of surgery, when you have removed old dressing, if wound is completely dry over the suture, right? If wound is completely dry, 100% safe, dry, 100% dry, no need of applying betadine. Only clean with normal saline or a spirit. That's it. I better clean with the normal saline. That after that you apply the, okay, now after that you can apply the dressing. But if you can see even the minor, even the small amount of the pus collection over the surgical side, please clean it with betadine. Clean it with betadine. Easy to understand? Okay, fine. See, please understand that. Suppose if you have a raw wound, see why it is said that, suppose if there was completely fully dry wound, and after that, if you are going to apply the betadine, see after that, what is happening? After that, what is happening here? Even because of the betadine, see there can be what? Again, inflammation. You are going to what? You are going to poke the wound again. So avoid it. Fine. Now next, what about Cydex, which is actually 2% glutaraldehyde. Cydex is what? 2% glutaraldehyde. 2% glutaraldehyde. We are going to understand one by one. See here, when I talk about Cydex, which is 2% glutaraldehyde. In our operation theater, whenever our staffs are supposed to disinfect the tube-like structure like endoscopes and cystoscopes, disinfection will be done by Cydex or glutaraldehyde. Here, Sidex will be used. 2% glutaraldehyde. Easy to understand? Fine. Now, one important question related to 2% glutaraldehyde. Please understand that. Very good, very good, very good. I can see your answer in like in chat box. Okay. See here. Now they see old time. Earlier they used to ask if you have to disinfect, operation theater, how you are going to disinfect. Earlier we were using only formaldehyde for the fumigation or fumigation of operation theater. For the fumigation of operation theater, earlier we were using formaldehyde, but now it is being done by, please remember, glutaraldehyde plus quaternary ammonium. Now it is used for the sterilization of operation theater. Since this is the new thing, you should remember it. How to sterilize operation theater, how to do fogging there. Okay, now fine. Now next is H2O2, hydrogen peroxide. When I talk about hydrogen peroxide, see here, when I talk about hydrogen peroxide, which type of wound you are going to clean with hydrogen peroxide? Okay, no? Whenever there will be infected wound, I'm sure you might have seen a diabetic foot. When you see diabetic foot, there will be so much accumulation of the pus. There will be so much pus collection there. When you see so much pus collection, only betadine, only normal saline will not help you. First of all, you pour H2O2, hydrogen peroxide, and after that, see, easily you can remove the infected part there. Easily you can remove. So H2O2 is also used for what? Infected wound, a very, very dirty wound where you are going to see so much pus collection, H2O2. Apart from that, H2O2 is also used to disinfect what? Like ventilator and the soft contact lenses. I know even for the plasma sterilization, we are using it. Okay, fine. Now, if you have to preserve the anatomical specimen, we are using what? Formaldehyde. I know earlier we were using gas fumigation to fumigate our operation theater, but right now glutaraldehyde plus what? Quaternary ammonium. Next, very, very important, that is sodium hypochlorite. Very, very important. Sodium hypochlorite. Repeatedly asked question. Nurse was taking the blood sample. During this sampling, few drops of blood fell down. How you are going to disinfect the floor? This was the question. Fine. So whenever there will be blood splage or like if there will be infected needle or syringe, you have to use what? Sodium hypochlorite. So in question number 13, I hope now it is clear to all of you that. So when you have to disinfect, if you have to sterilize the endoscopic instrument, you have to use what? Sidex D. Next question. See, the second question. See, this question was asked in AIMS also previously. Okay, no? Previously. So while taking a blood sample and spill few drops of blood on floor, which of the following should be used to clean it? Basic clinical management, you should understand how you are going to clean it. Fine. Now you should see the amount of blood. It is more than 10 milliliter or less than 10 milliliter, right? Fine. Very, very important. So out of these four, now I'm sure you can easily exclude other option and you can directly mark sodium hypochlorite here. But how to disinfect, do understand here. First of all, how you are going to perform, how you are going to disinfect it. First of all, you have to save yourself. First of all, you have to wear the PPE. Okay, no? Fine. After that, you are going to use what? Absorbable material. You are going to keep absorbable material over this spillage. After that, you are going to remove it. Then you are going to disinfect. Disinfect. Please understand here that PP is extremely important. PP means what? This is the personal protective equipment. Fine. So fine. If amount is less than 10 milliliter, less than 10 milliliter. After wearing the PP, first of all, you are going to wipe the blood, right? Okay, you are going to keep the absorbable material. You are going to clean it, and then you are going to disinfect with the help of sodium hypochlorite. But if it is more than 10 milliliter, first of all, you are going to keep absorbable material. And after that, you are going to pour up to 10% sodium hypochlorite, wait for some time, at least for 15 minutes. After that, you are going to remove it. Fine. Again, you are going to disinfect it. See, they are not going to ask you the procedure, but you have to remember the use of all these things, where we are using H2O2, we are using sodium hypochlorite or ethyl alcohol or betadine. Easy to understand? Chalo, fine. Next. See, answer me this question. Answer me this question, please. This is also a question related to microbiology, but you will see this question in orthopedics also. Right now, ortho emergency, you will see this question. See, a patient presented with swelling in knee with severe tenderness, redness, swelling, inability to move the limb and fever. चलो ठीक है. Fever है, swelling in knee, severe means it is very, very painful, redness, swelling. On examination, affected area is warm. Patient does not remember any history of the trauma, means there is no accident, no trauma. So here, are you going to suspect the fracture? No. See here, when there is fever, see, as per the clinical condition, as per the presentation of knee, warm, you can see there is a wound also. What is happening? There is a wound also. There is history of fever. Fever means what? Infection is there. Fever means infection is there. This kind of presentation without fracture, until and unless it is proven, answer will be what? This is a case of infection. This is a case of septic arthritis. Septic arthritis. Septic arthritis. Always understand that hot swollen joint without any injury is septic arthritis until it is going to be proven. So how septic arthritis? Now you tell me what is the most common cause of septic arthritis? If you remember the points of your microbiology, what is the most common cause of septic arthritis? Bacteria, fungus, or virus? Or bacteria? Which bacteria? Yes, Staph aureus. Answer is Staph aureus. Most common cause of septic arthritis is Staph aureus, which is a bacteria. So this is a case of bacterial infection. You have to understand the clinical condition and then you have to mark the right answer. Easy to understand. So when septic arthritis can happen, see here, if there is some other infection in the body. So from other infection, or if there will be direct penetration of any pointed object like any knife or any weapon. I know if there, so after injury, okay, no, so after injury, whenever after injury or from some other already existed infection, whenever there will be accumulation of germs in some joints like knee or shoulder, right? Knee or shoulder, fine now? At some joints, knee, shoulder, hip, or jo bhi joints mein, fine now? So after the accumulation of Staph aureus, there will be what? Septic arthritis, septic arthritis. So do understand some points related to Staph aureus, because this is the most important bacteria for the patients also, for the doctors also, for the medical students also, because every time they will ask you one question related to Staph aureus. Always understand that Staph aureus is the most common cause in so many conditions, right now? So many conditions. Even when you talk about, you know, like ingrown hair, like a furuncle hai, carbuncle hai, right? SSS syndrome. Okay, now for all these, actually, what is the most common? What is the most common reason? It is what? Staph aureus. Okay, septic arthritis we can understand. Even for the osteomyelitis also, osteomyelitis, how you are going to understand? Suppose if you are working in emergency department, suddenly if a father is coming there with his baby, right now, and father is saying that my son fell from the bed and now he is having fracture. So please see this. And when you do the X-ray, bones are completely normal, no fracture is there. So you are asking the father, okay, did you see your child falling from the bed? Well, no. Well, this condition is there for last 1 or 2 days. Okay, fine. Fever is also there. At that point, swollen joint, right now, fever, you should understand some kind of infection, right now, some kind of infection. Fine. Now, next question is that, see, at which place, epiphysis, diaphysis, or metaphysis, the most common location where bacteria is going to get accumulated? Where? In osteomyelitis. Answer is what? Metaphysis, right? Answer is what? Metaphysis. Metaphysis, because the most vascular structure of the bone is what? Metaphysis. So there easily, so there will be what? Hematogenous spread. Hematogenous spread. Okay, so what is the most common location? Metaphysis. Even for the psoas abscess, epidural abscess, or the skeletal muscle infection right now, okay, like especially seen in the HIV infected people, even for all these, Staph aureus is the most common organism. Next patient. A patient of pneumonia who is under the treatment for last 10 days, has fever with chills, nausea and vomiting, and diarrhea. On examination, there is tachycardia, rapid breathing, low blood pressure. See here, low BP. See, always understand that. See here, low blood pressure and high heart rate. High heart rate, or you can say pulse rate. So it means what? Patient is going into shock. It means what? Patient is going into shock. So whenever you are receiving a patient of shock, what is the first investigation you should do there? Obviously, you have to check blood pressure. So do remember, when pulse rate is more than 100 or systolic blood pressure is less than 100, you should suspect that your patient is in shock. So fluid circulation, so fluid management is extremely important now. Now see here, in this condition, basically this is the patient of pneumonia who was already on the treatment for last 10 days. Okay, for last 10 days, but now patient is having what? High fever with the chills. Fever with the chills. Okay, fine. I can suspect that there is some infection. And then nausea, hai, vomiting also, diarrhea also. Patient is going into shock also. Suspecting bacteremia. Now the clinician who was looking after the patient, he is suspecting what? He is suspecting bacteremia with the Staph aureus. Means if a patient who was already suffering from a disease, and now as per the clinical signs and symptoms, if you are suspecting that there can be what? Bacteremia. Bacteremia means what? Patient is in sepsis. Patient is in what? Sepsis. Patient is in sepsis. Now the question is whether patient is completely into sepsis or not. How you are going to confirm it? So for that you have to recollect the sample. You have to collect the sample, no? Right now. So from, see, specimen collection should be taken from sputum, in this case, urine, vomiting, or blood. Here, clinician is suspecting what? Sepsis. See, do you understand the meaning of sepsis? How a patient is going into sepsis? Suppose if I have operated a patient, maybe over the bile duct, I have operated a patient. Next day, see, after the bile duct operation, obviously you can suspect that there can be a leakage of the bile juice. After the surgery, now your patient is already admitted in the ward. Just, okay, see, after the surgery, day 1, day 2, day 3, like in the beginning, patient was normal, but on day 4, see, every day, see, after the surgery, you are going to place a tube there, right now, at the place of surgery, right? After that, every day, you are going to check how much bile leakage is there. But on day 4, now patient is having what? High fever, high pulse. Okay, now patient is having what? High fever. Patient is having high pulse rate, right now, and low BP. You should understand that there is infection. Patient is in sepsis now. So there is a level of septicemia, right? There is a level of sepsis. So first of all, now you tell me, whenever you want to confirm it, whether patient is having septicemia or not, which sample you are going to check? Okay, some of you might be thinking this was the case of pneumonia, so you have to take a sputum. Okay, sputum or whatever. But please understand that now patient is already on the treatment for the last 10 days. Now, most important is that, see, whenever there will be accumulation of any germs or bacteria in the blood, after that patient can have what? After that patient will be having bacteremia. So you have to do what? Blood culture. You have to do what? Blood culture. After the blood culture, only you can understand which bacteria or which organisms are there. So you have to take the sample from blood. Now, if you have a patient suppose if you have a patient who is having severe cough with the sputum, he is having productive cough, greenish color or yellowish color, fever for last 14 days, and the productive cough, nausea, vomiting, right? So here you are suspecting a patient is having what? And after that patient is also having night sweat. So now you are suspecting patient is having TB. Okay, pulmonary cough, fine. No? So now you tell me, in a case of the TB, like from where you are going to collect the specimen? Obviously from a sputum, Okay, fine. Now, when you are suspecting that a patient is having UTI and all, urinary tract infection, at that time you can take medicinal urine sample. Easy to understand, no? So do understand that in a case of urinary tract infection, you have to take sample of what? Urine, midstream urine. Respiratory infection, obviously sputum. Suppose if you can see any wound there, suppurative lesions, right? Wound. So you have to take sample from either the pus, a wound swab culture you have to take. Okay, suppose if you are working in plastic surgery, burns and plastic surgery department, you have a patient who is having a wound. Even after using multiple, like antibiotics, high doses antibiotics, your patient is not responding. Right? So you don't know the patient is susceptible or resistant to which antibiotics. So here also you have to recollect the sample, right? Now, so here you are going to take the wound swab, and after that you are going to do the culture. Bacteremia case, blood culture. Food poisoning, yes, fecal matter, vomitus and food. Or if a person is a carrier of something, or a carrier is something, then like the typhoid and all, then nasal or the peri-anal swab. So do understand how we are going to differentiate bacteremia and septicemia. See, only remember a few points related to bacteremia and septicemia. See here, okay, I can say that a bacteremia is a milder form of septicemia. Here, there will be only accumulation of bacteria in blood. You can see bacteria is there in blood. But in septicemia, there will be multiplication of bacteria, right? So there will be so many bacteria. Bacteria here, right now, as of now, bacteria is not producing any toxins. But in septicemia, bacteria, they are going to produce the toxins. So septicemia is very, 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 very serious. Bacteremia is most of the time, this is self-resolving. But septicemia, you have to start high dose antibiotic. High doses of antibiotics. I hope these points are clear to all of you. Okay, see, sometimes they can ask you the picture-based question. See, like in the hospital, when you will be practicing, no? So this kind of bottles will be there. So these kind of bottles are used for what? To collect the blood sample for the blood culture. Okay, so these are called as blood culture vials. Next, a 55-year-old male is admitted to hospital with complaints of severe pain in lateral aspect of his left calf and a small amount of pus discharge from the ingrown hair. See here, small amount of the pus discharge from ingrown hair. So when you see the option, you can say, okay, this question is related to microbiology. So first thing, we should strike your mind that which bacteria is mostly available or present at the nearby hair, ingrown hair. So there is a pus collection. Okay, fine. On physical examination, local area is found to be red, warm, and the tender. Now pus is aspirated, and it is sent for the culture. Fine. No? So when you are going to do the gram staining, it is showing positive 𝗂𝗃 in clusters. You are having so many information in this clinical question. When you are staining, when you are doing gram staining, you can see what? Positive 𝗂𝗃. Gram positive 𝗂𝗃, and that too in the clusters. Okay, no, like this, like the clusters. Blood culture is showing what? Golden yellow pigmented. And then what? Hemolysis is also seen. RBC destruction, right? So complete, that is beta hemolytic. See here. Now, do you think I need to explain you this question? Everything is given there. First of all, when I have given you one hint here, see here, ingrown hair, which bacteria most commonly there? Obviously, they are Staph aureus. Okay, first answer to mujhe yahan se mil gaya. So, okay, fine. But when I talk about gram positive 𝗂𝗃, okay, you can say, sir, this can be a Staph aureus or this can be a Streptococcus also, right? No, yes, you are very much right. Hai? Okay, this can be a Staph aureus also, this can be a Streptococcus also. But if gram positive 𝗂𝗃 in the clusters mein hai, this is a Staph aureus. But if it is in a chain like this will be a Streptococcus. So Streptococcus is ruled out now. Easy to understand. But you can ask, sir, why not Staphylococcus epidermidis? Okay, Staph epidermidis. This is not responsible for the wound over ingrown hairs and all, but this is the most common cause for what? This is related to prosthetic valves. This is related, the most common infection related to the prosthetic valves, especially if I talk about endocarditis here, endocarditis. So there you are going to see the maximum role of Staphylococcus epidermidis. Fine, no? So as per all these clinical situation, clinical condition, answer is what? This is the case of Staphylococcus aureus. Staphylococcus aureus. Staph aureus. See here, like when you see, these can be your picture-based question. This can be your picture-based question. See, nutrient agar will show what? Golden yellow pigmented colonies like this. See here, hemolysis will be alpha hemolysis, beta hemolysis, and the gamma. When there will be what? Complete lysis of RBC. And if there will be, okay, like this, right now. So this is what? Beta hemolysis, right? Beta hemolysis. This is shown by Steph Aureus. What about, see here, when you are going to examine on the mannitol salt agar, right now? Fine. Because of the fermentation of the mannitol, you are going to see what? Yellow color here. All these can be your image-based questions also. Fine. All right. Now, next question, please. See here in this question, no? Alpha hemolysis, beta hemolysis, and the gamma hemolysis, right now? Fine. See, whenever there will be separate hemolysis, that is called the beta, whenever like the partial alpha and no actually gamma. So I would suggest you please revise all these topics related to Staph aureus. You have to revise all the points. Next question. A person suffered from a small injury over his left thumb. In the beginning, left thumb, small injury. After 2-3 days, there was acute onset and a rapid progression in wound as shown in photo. See in the beginning, day 1, see picture number 1, day 1, there is a small injury, but what is happening here? See what is happening here? Just within few days, just after the 2 to 3 days. Now what is happening here? There is what? Acute onset, and there is what? Rapid progression to this condition here. Superficial infection was there, but suddenly after the epidermis, now there was the involvement of dermis and then subcutaneous tissue. Now even inside, deep inside, now see here, deep inside. Now you tell me, what is the name of this condition? Do you think this is just cellulitis? Do you think this is just superficial infection? See here, in this condition, after this patient is complaining of severe pain, malaise, fever, and the chill. Fever and chills means what? Obviously infection. Fever and chills. And see, please understand that all infection. See here, reason for the fever. Root cause for the fever is what? Always infection. Except in a case of burns. Day 1. In day 1 after burns, there will be fever, but that is not because of any infection. That will be because of higher rate of metabolism. So burns is actually the non-infectious cause of fever. In this condition, see here, patient is having, see, first of all, injury was there, and after that there was acute onset, then there was sudden progression to this case. Now you tell me here, fever, chills, everything is there. It means there is infection for sure. Out of these 4 options, which of the following is the most probable cause or the causative agent for this condition? So first of all, you tell me, what is the diagnosis? I'm going to teach you some points related to cellulitis and necrotizing fasciitis. First of all, do understand what is the meaning of cellulitis and necrotizing fasciitis. What is the meaning of cellulitis and necrotizing fasciitis? Cellulitis and necrotizing fasciitis. Whenever there will be involvement of superficial layers of the skin or up to the subcutaneous, okay, fine. Up to this part, this is cellulitis. But if there will be deeper penetration, much more deeper penetration, now this will become what? Necrosis. This will become what? Necrotizing fasciitis. So, okay, first of all, let's solve this question. After that, I will teach you more points related to this. Necrotizing fasciitis means what? First of all, means like there will be necrosis, there will be what? Necrosed area, and after that there will be involvement of the fascia also, means deeper layers, right? Or deeper layers. So what is the most common cause here? Most common cause of necrotizing fasciitis is what? Streptococcus. Most common cause is what? Streptococcus pyogenes, right? Streptococcus pyogenes. Out of these four, where you are going to keep Streptococcus pyogenes here? Group A Streptococcus. There is only one here. Group A. Group A Streptococcus. Group A. See, this is the only species here in the group A. So now the question is there, how you are going to see necrotizing fasciitis. Necrotizing fasciitis. Whenever, first of all, do understand that, first of all, there should be what? Injury. After the injury to the skin. Most common organism is a Streptococcus pyogenes. But this can also occur because of a Staph aureus. Staph aureus. After the surgery also, if there will be gastrointestinal breach, whenever there will be abdominal surgery, right? Abdominal surgery, if there will be breach, if there will be injury in the defensive mechanism, like look at the defensive structure inside the abdomen, yes, these can lead to what? This can lead to necrotizing fasciitis. Necrotizing fasciitis. See here, like when you see picture number A, B, C, D here, no? A, B, C, D here. A, B, C, D here. Easily you can understand. See, I started with a small wound here, but after that, see. After that, see. Fine. So acute onset just followed by sudden progression to higher level of disease. Fine. So what are the risk factors for necrotizing fasciitis? First of all, any kind of injury, or if a person is already suffering from diabetes mellitus, or maybe you can say in any condition where a person is immunocompromised. So even in the diabetes, and after that, like if there will be like a renal problem, or there can be infection after surgery. So these are the risk factors for necrotizing fasciitis. Fine. Now, question is cellulitis and necrotizing fasciitis. I would say that beginning phase of necrotizing fasciitis is called as cellulitis. Beginning phase. But if you do not manage this cellulitis, this can easily progress to, and after that, if patient will be having necrotizing fasciitis, where patient will be having severe physiological changes, and after that there will be severe disaster of the multiple organ, then patient can have what? Multiple organ dysfunction, which can even kill the patient. Fine. Do you understand here? Now the question is that, one is called as cellulitis, second is called as erysipelas. These two are also important. Fine. How to differentiate these two? When I talk about erysipelas, see, this is also caused by Streptococcus pyogenes. And sometimes Staph aureus also. Okay, fine. See here, erysipelas, here there will be involvement of upper subcutaneous layer. But in cellulitis, there will be involvement of deeper subcutaneous layer. When I talk about erysipelas, what is the most common location where you are going to see mostly you are going to see over face. Mostly where you are going to see over this cellulitis, mostly over legs. Fine. When I talk about erysipelas, mostly it will be self-resolving, self-limiting, you can say. But cellulitis, you have to do aggressive management. You need to manage the case. Now see some pictures, and after that you will be having more clarity. When I have to differentiate cellulitis and erysipelas. First of all, here you are going to see only what most common location is face along the nose and cheek. Here most common location is the leg. Second, here you are going to see the involvement of upper subcutaneous layer. Cellulitis, this will go more deeper subcutaneous layer. Easy to understand. Erysipelas is self-limiting, but cellulitis, you have to start high dose antibiotics. Now, let's differentiate cellulitis and necrotizing fasciitis. Cellulitis and necrotizing fasciitis. Cellulitis is the beginning phase, you can say, but necrotizing fasciitis, where you can see a bluish discoloration, where there will be necrosis, and necrosis will already be starting there right now. So necrotizing fasciitis, see here, this will be very this can easily go much deeper into the body layers. Fine. And cellulitis, that is the beginning part. See this picture, and after seeing this picture, what is your answer? This is cellulitis or a necrotizing fasciitis. Answer is easy to understand. This is what? Necrotizing fasciitis. Next question. A 30-year-old male presented in hospital with high fever, headache, drowsiness, mental confusion. On examination, neck is stiff. Suspecting meningitis, most of the students will stop here only. And after that, so directly a student will read what is the most probable causative agent. And most of the students will mark what? Answer A, Neisseria meningitis, right now. Because you are suspecting this is a case of Neisseria meningitis, because high fever, headache, mental confusion, neck stiffness, okay, meningitis for sure. So answer will be Neisseria meningitis. But you did a mistake. You did not read all the points. See here, suspecting meningitis, cytopathological examination was also performed. Zinc preparation here, zinc smear, where there was presence of multinucleated giant cells. Where do you see multinucleated giant cell? Do you see in Neisseria species? When I talk about Neisseria gonorrhea, I will be seeing kidney shaped, okay, no? Or you can say coffee bean shaped, okay, fine. And Neisseria meningitis, I would say what? Lens shaped. But see, these kind of symptoms can also occur in the encephalitis, no? Encephalitis, I know. Herpes simplex virus. Herpes simplex virus, which is the most common cause of the epidemic what? Encephalitis. When you do cytopathological examination, herpes simplex virus will show multinucleated giant cells. Answer is herpes simplex virus. Answer is C. Answer is C. Right? Easy to understand. Answer is C. Fine now? Please understand that this is the most common cause of what? Acute sporadic viral encephalitis. See, if I ask you herpes simplex virus 1 or 2, which is more commonly involved here? See, upper part of the body, herpes simplex virus type 1. Lower part of the body, herpes simplex virus 2 type. Easy to understand. Fine now? Fine. Herpes simplex virus, when it is going to cause the meningitis, it is called a what? It is called the Mollaret's meningitis. Mollaret's meningitis. Mollaret's. Fine now? So whenever you are going to do the cytopathological examination, if there will be presence of herpes simplex virus, you are going to see what? You are going to see what? Multinucleated giant cells, and there will be what? Inclusion bodies, what? Like 𝗵𝗵𝗪𝗔 body. 𝗵𝗵𝗪𝗔 body. These are your questions. Now, related to clinical practice, whenever you are suspecting neck stiffness, whenever you are suspecting what meningitis, you are performing two examination, easy to understand, and you will be having two signs repeatedly asked question. One is called as the Kernig sign. Second is called as the 𝗵𝗺cie sign. Final. So how to perform? See, after the flexion of knee, please understand that. See what is happening here. Extension of knee. Whenever you are going to perform this kind of movement here, no, like there will be what? Obstruction. There will be resistance, or this will be what? There will be actually severe pain. There will be severe pain. Final. And what about the 𝗵𝗺cie sign? See, right? These two are extremely important. Repeatedly asked question: in which disease you see Kernig sign and the 𝗵𝗺cie sign, right? 𝗵𝗺cie sign. Fine. After the flexion of neck, there will be this kind of movement. There will be what? Knee flexion. Next question, please. A 25-year-old male came with history of dysuria and noted some pus-like drainage. Dysuria and pus-like drainage in his underwear and at the tip of his penis. He gave history of being sexually active with 6 or 7 partners in last 3 months. His physical examination showed yellow urethral discharge. Yellow urethral discharge. So basically, this is a see, after reading the question up to this point, we can say that this is a case of what? Sexually transmitted diseases. Fine now? Okay, fine. And there is also tenderness at the tip of the penis. See here, examination of urethral discharge revealed intracellular gram-negative diplococci. See, whenever I'm giving you big questions, or whenever any examiner will give you big clinical question, do understand that they will give you so many hints. See here, the gram-negative diplococci. Okay, fine. Okay. When I'm suspecting sexual diseases, right? STD. Okay, fine. So I can easily rule out. Fine now? Do understand that if an adult is there sexually active when he has performed unprotected sexual intercourse with multiple partners, fine now? Fine. Unprotected sexual intercourse, this can lead to a sexual transmitted disease that is called as gonorrhea, right now. So out of these 4, what will be the causative agent? Answer is Neisseria gonorrhea. Neisseria gonorrhea. How you are going to treat? If I ask you what is the drug of choice for Neisseria, what is the drug of choice for this STD? What is the drug of choice for gonorrhea? What is your answer? Ceftriaxone, right? Ceftriaxone injection you have to give. Please understand that. See here. Neisseria gonorrhea, gram-negative diplococci. Okay, fine. Now, on the basis of the nature of the discharge, how you are going to understand? Okay, fine. This is the STD, but this is actually gonococcal urethritis or non-gonococcal urethritis. First of all, you see the nature of the pus discharge. If it is a thick purulent discharge, this is gonococcal. This is gonococcal. If it is actually very thin and the mucopurulent discharge, okay, this is actually non-gonococcal, like chlamydia infection. How you are going to treat the case of the gonorrhea? Ceftriaxone. Please understand that you have to use what? Injection of ceftriaxone. Along with that, you have to give oral azithromycin. When I talk about the non-gonococcal infection, how you are going to treat? You are going to give what? Oral azithromycin. All these are your clinical questions. See, even I'm solving the microbiology question, but we are learning so many clinical things here, right? So this is related to your basic clinical practice. Next question. A 45-year male chef gets fever once in 2 to 3 months. He also gets headache, chills, abdominal pain, myalgia, rashes, nausea, and vomiting. Fever rises gradually to a higher level with every spike, then falls down, but it does not touch normal. Fever is like this. Fever is like this. Okay, like a step ladder pattern. So now basically when I see the clinical condition here, I'm suspecting that this is the case of, see, as per the condition here, severe, high fever with the chills and abdominal pain. Which type of fever you suspect here? Which type of fever? See where you are going to see what? Where you are going to see a step ladder pattern. High fever with abdominal pain and a step ladder pattern of fever. You should suspect what? Typhoid case. Typhoid case. Okay, fine. So as per the clinical condition, I can understand that patient is suffering from the typhoid. All right. Now, what is the common organism? What is the organism which is responsible for the typhoid? Salmonella typhi, right? Salmonella typhi. But up to this part, I understood medicine part, I understood pharma part, I understood microbiology. I have diagnosed the case. But there is a surgeon. Surgeon performed cholecystectomy in that patient. What is the reason for this? First of all, you tell me surgeon did right or wrong. He removed his gallbladder. He removed his gallbladder. Why? So first of all, you tell me he did right or wrong. Okay, fine. See, do understand that he did actually right. See, please understand that. See, that chef actually and that chef. I know. See, please understand that as per the clinical condition, we can understand like he's a patient of, like most of the time he's getting the typhoid, but after every 2 months, so like see 6 times in 1 year, more than 6 times in a year. So do you think like he can be under the like he can be in trouble? See, 6 times a person is getting the typhoid, obviously like he will be in more trouble. So I can say that he is also the case of what? Typhoid carrier, right? Why he is having fever again and again? See, what is the reason for this? Salmonella typhi, Salmonella typhi, Salmonella typhi, right now. Now you tell me, what is the relation of Salmonella typhi with bile juice? With bile juice. Salmonella typhi loves bile juice. It loves bile juice. Wherever there will be bile juice concentration, wherever there will be accumulation of bile juice, especially in the biliary tract, I know wherever there will be accumulation of bile juice, there will be what? There will be accumulation of Salmonella typhi. And because of this, what is happening is, so when we talk about the gallbladder, when we talk about the gallbladder, what is happening? And if you have a typhoid carrier, please understand that. If you have a typhoid carrier, please understand that here also in a case of typhoid carrier also we can perform which type of operation here? In advance, we can remove the gallbladder. Prophylactic cholecystectomy. Now the question is that in which condition we can perform this kind of surgery? Means see, in advance we have to remove the gallbladder. In which conditions? Like related to surgery? Fine, related to surgery? Answer me please. See, like first of all, we have understood that if there will be a case of typhoid carrier, okay, if there will be a case of the typhoid carrier, where a person is having fever again and again, okay, fine. There also we can perform this surgery. We can remove the gallbladder because there will be more accumulation of bile juice, and because of that, there will be more accumulation of Salmonella typhi. In some other conditions where we can perform the prophylactic cholecystectomy, yes, when a person has to go through, suppose if there will be lung transplantation or heart transplantation, or if there is a silent gallbladder stone, size is more than 3 centimeters. Fine. So actually there are so many reasons, so many conditions, but these are the conditions. These are a few of the conditions where you can perform prophylactic cholecystectomy. Now the question is that what is happening here? Do understand that typhoid bacilli multiply in gallbladder. Fine. So now I hope this is easy for you to understand, to rule out other options. When we have diagnosed the case that this is the case of typhoid, do you think causative agent is Aedes aegypti? No, Aedes aegypti is responsible for what? This is responsible for dengue, right? Dengue fever, not typhoid. So option 1 is wrong. Option number C here, Salmonella typhi is resistant to bile juice here. Actually, no, right? Salmonella typhi, it loves bile juice. It is a case of this kind of fever. No, in chikungunya fever, yes, fever pattern will be there, but there will be severe joint pains. Fine. So what is the reason of surgery? Option number B is right. Colonization of Salmonella typhi is more in higher concentration of bile juice. Answer is B. I hope this is clear to all of you. Okay, now you tell me, whenever there will be a case of the typhoid or the intestinal TB, which type of ulcer you are going to see? I hope you have learned in your pathology also, micro also, surgery also, medicine also. Now you tell me which type of ulcer you see in typhoid, which type of ulcer you see in intestinal TB or amoebiasis. Batao. Where you are going to see transverse ulcer, where you are going to see longitudinal ulcer, where you are going to see flask-shaped ulcer. These all can be your one-liner question. Very easy to understand. Shall I find? See here, when you can see transverse ulcer like this, right? Like in a horizontal manner, right? A horizontal manner, tuberculosis. But when I talk about the typhoid, like a tie, so a tie is placed in longitudinal manner. In typhoid, you are going to see what? Longitudinal ulcer. Flask-shaped ulcer will be seen in amoebic ulcer, right? No, amoebiasis and all. Amoebiasis, right? Next. A young adult female was admitted to the hospital with intense headache, abdominal discomfort for the past 7 days. Abdominal discomfort. She also had developed a fever, which is of remitted type with gradual rise in a step ladder fashion. A step ladder fashion means what? See, it is okay, see, it is like, suppose if it is increasing and then decreasing, if it is increasing and then decreasing, right? Okay, now, so this is what? Step ladder pattern. But this is not, okay, but this is not getting 100% to normal level. Fine, so this is called a what? Step ladder fashion. Step ladder fashion. Fine, now. On examination, she was toxic with the temperature. It means what? Septicemia is there. Okay, fine. Tongue was coated, means a white tongue. Okay, mild splenomegaly. After seeing fever with abdominal pain and all these clinical conditions, yes, patient is suffering from. Now you tell me, what is your diagnosis? Do you suspect that this is a case of dengue, chikungunya, or Kala-Azar, or this is the case of malaria, or this is the case of typhoid? What is your answer? Your answer, please. Yes, easy to understand. No? See, this is very easy to understand. This is the case of what? And this is the case of obviously the typhoid, right? Typhoid. Okay, fine. So now when you have a patient of the typhoid, how you are going to see here, which investigation would you advise to diagnose the case? First of all, this is not the case of the dengue, right? No, so dengue के लिए क्या होता है? So NS1 antigen test, this we are doing for what? है ना? This is for the dengue, right? No, okay. This is not the case of the malaria, right? No, malaria में क्या होगा वहाँ पे? है ना? Shivering and chills, right? No, right? Okay, fine. So morning and evening differences and all, right? Okay, so we are not going to do the peripheral smear for malaria. See, we are not suspecting the tuberculosis here, right? The tuberculosis we are not suspecting, so no sputum, right now. But when we are suspecting this is a case of typhoid, तो typhoid के लिए क्या पढ़ा था? एक mnemonic था ना, BASU. Blood है ना, blood test, antigen test, stool test, right? Stool test and urine test. First week, second and third week, and fourth week after the fever, right? No? So how you are going to understand? Please remember that if you have a patient in the first week after the fever, this is a case of what? This is the case of enteric fever. You can say the typhoid. First week, what you are going to see here? You are going to do blood culture. Blood culture will be more effective. But second week, see, yes, second week, you have to, especially second and third week, you have to do what? Vidal test, antigen test, right? No, antigen test, Vidal test, antigen test. Even if they are going to ask you now, it is on a 14th day. If they are going to ask you on a 14th day, what will be the best for investigation on 14th day? Obviously, this will be Vidal test. Easy to understand, no? Fine, no? Okay, fine. So second and third week, you have to do what? Vidal test, antigen detection, as well as you should also do what? Stool culture, stool culture. Fourth week, okay, stool culture. Okay, stool culture and all, right? Okay, fine. So now this is very easy to understand. Now you have the patient of the typhoid. You are going to do what? Blood culture as well as Vidal test, because patient is presented to your department on 7th day, right? Now 7th day. Fine. BASU, blood culture, antigen test, stool culture, urine culture. First week, second and third week, fourth week, stool culture, right? Okay. Next, in order to minimize the risk of the transmission of infection, donning and doffing, wearing and removing of PPE must be performed in which sequence? See, related to, since we are still living in the era of the pandemic disease, right? The corona. So we have learned so many things related to PPE. One question you can anticipate from PPE also. One question you can anticipate. Okay, no? So how to wear? Always remember that first of all, you have to wear the gown. After that, you have to wear the mask or respirator. After that, face shield. And then at last you have to wear the gloves. So out of these four, which one is the right sequence? When I talk about the like a wearing of PP, wearing means the donning. Say donning means wearing of PP. Doffing means removing of PP. This is the right answer. So now, always remember, this can be your question. First of all, you have to wear the gown. After that, mask, or you can say what, respirator. After that, face shield. At last, gloves. How to remove? First of all, you have to remove the thing which you, with the help of which you already had touched the patient, right now. So first of all, you have to remove the gloves. After that, easy to remove, face shield or the goggles. After that, gown. At last you have to remove mask or the respirator. Fine. First to wear is gown. First to remove is gloves. Easy to understand. Fine. Okay. Now, next question. See, whenever a person is going to do hand rub, sterilization or hand sanitization, minimum for how many seconds you have to do it? Hand rub should be done at least for 20 seconds. At least for 20 seconds, hand rubs. Hand wash, minimum for 40 seconds. Minimum for 40 seconds. I hope you know these 7 steps of hand washing. PPE kit, how to wear, how to remove. With donning and doffing, very, very important. Next, while suturing a local wound, a surgeon got needle prick injury. See, needle prick injury is very, very important topic. You have to understand. So risk of transmission of blood-borne virus is highest for. See, remember the rule of 30%, only 3%, and then 0.3%. Highest risk is for hepatitis B virus, 30%, and then hepatitis C virus, and then HIV. HIV, needle prick injury is very, very common, no? Okay, no, so like even when you will be doing your internship, okay, during suturing, okay, you can get needle prick injury. So you have to be very, very careful. I know. So like related to solving the question, you have to understand that, okay, see here, hepatitis B, hepatitis C, and HIV. These are actually the blood-borne viruses, right? So remember the rule of the 30%, only 3%, and 0.3%, fine? So highest risk of the transmission is of hepatitis B virus, then C virus, then HIV. Right? Remember this one. Needle prick injury. Next question. See here. A patient with benign prostatic hyperplasia was admitted in hospital for 3 weeks. He subsequently developed suspected catheter-associated UTI related to Foley's catheter, right? Foley's catheter. Tip of the catheter was sent for culture and was grown on blood agar. After 24 hours, the blood agar shows the appearance as shown here. You can see the picture here. So this is something like this. This is like what? This is like what? This is something like swarming motility, right? This is something like swarming motility. See here. Okay, what kind of, right now, this is what? Swarming motility. Fine. In this manner, swarming manner, where do you see Foley's catheter related UTI can be seen? Swarming motility, swarming growth, where you can see out of these 4 options. What is your answer here? Yes, you can see where in the Proteus mirabilis. Yes, this is one of the most important causes for catheter associated UTI. Proteus mirabilis. So swarming growth you are seeing where in Proteus mirabilis. See, one important phenomena is there that is called as Dine's phenomena, right? Dine's phenomena. Where do you see out of these 4 options? Where do you see Dine's phenomena? Can you answer me? Same answer will be same. Here only you are going to see the Proteus. Okay, now? So please understand that. Okay, so like there can be, see, like overall this is all about what? Swarming. Fine. So this is related to the Proteus. Now, what is the meaning of the Dine's phenomenon? See, there can be different strains of the Proteus. Okay, there can be different strains of the Proteus. So what is happening here? If you are going to culture it, fine. So now after that, when you are going to see this swarming, okay, when you are going to see this swarming, and if there will be what is happening here, see, if the 2 strains, they merge incompletely and they remain separated by a line of demarcation. What does it mean? It means 2 different strains are there. 2 different strains are there. But if two strains are going to merge completely. You do not see any line of demarcation. It means what? Strains, two strains are similar. This phenomena is called as Dyene's phenomena. Repeatedly asked question. Where do we see Dyene's phenomena? Dyene's phenomena is seen in Proteus mirabilis. See here, like related to motility, like swarming motility, swarming growth, repeatedly asked questions. Sometimes they will be asking you one-liner questions. Sometimes they can ask you in a clinical manner. Clinical manner, I already have asked you. See, the purpose of taking this exam is that you have to understand what kind of clinical questions they can frame. In this manner, you have 1 month, you have to solve the question. I know you should understand that, okay, even the non-clinical questions can be framed in this manner, in this clinical manner. I know. So where do you see tumbling motility? Listeria, right? Listeria. Where do you see a stately motility? Clostridium species. Mycoplasma will show which type of motility? Gliding motility. I'm sure all of these things, see, all these things you would have learned in your microbiology. All these are your one-liner questions. So please memorize all these topics. These are repeatedly asked questions. Next question, see here. A 49-year-old male was admitted in burns department with total body surface area of 65%. He was admitted for 2 weeks. He was on high-dose antibiotics, high-dose antibiotics. He was admitted for 2 weeks. First of all, he was admitted for 2 weeks. He was on high-dose antibiotics, high-dose antibiotics. Please understand that. Suppose if a person was on the linezolid or high-dose antibiotic, what is happening here? Because of the high-dose antibiotics, even the normal flora of the gut will be killed. Even the normal flora of the gut will be damaged. After that, patient will be having some abdominal problem. So now patient is complaining of abdominal pain and severe diarrhea. Colonoscopy findings are shown below. What is happening here? Whenever there be, see, overuse of antibiotics, high dose antibiotic, it can kill the normal flora of the gut. And after that, there will be what? There will be a spread of a pseudo membrane over the GIT part. See here, this yellowish or the whitish part here, no? So small plaques here, right? Small plaques. These are not actual membrane. These are actually called as what? Pseudo membrane. Since it is happening in the colon and now patient is having inflammation everywhere, what is happening here? It is called a what? Pseudo membranous colitis. As per the condition, this question can be asked in pathology, in medicine, in surgery department, even in pharma also, whenever they will have, okay, whenever they need to add the drug of choice or the best drug to treatment and all, right? Okay, fine. So what is the diagnosis? After seeing the clinical condition, now you tell me what is the diagnosis? Diagnosis is pseudomembranous colitis. It is called as pseudomembranous colitis. Fine. See, whenever there will be pseudomembranous colitis, which bacteria will be developing more? Answer is Clostridium difficile. Clostridium difficile. So now Clostridium difficile is the most common organism associated with this condition. Yes. What I have taught you, high dose antibiotics or the broad spectrum antibiotics, do they have a role in this pathology? Yes. What is the best medicine to manage this patient? Oral vancomycin. This is the best medicine. Oral vancomycin. This is also right answer. Now option number 3 here. Option number 3. Is it a case of Crohn's disease? No, this is not a case of inflammatory bowel disease. So out of these 4 options, which one is incorrect statement? Wrong. Answer is only 3. Only 3. Only 3 is wrong, right? Answer will be B. Next question. After needle stick injury or needle prick injury, a doctor get exposed to body fluids of patient. Which of the following is the first step in post-exposure management? Means you were working in surgical emergency, you were suturing a patient. While doing the, while performing suturing, you got needle prick injury. Okay, needle prick injury. Or after that, you can say that, yes, you got exposed to the body fluids of the patient. And at this moment, you don't know, because this was a local case, you don't know, you don't know whether patient is already infected by hepatitis B, hepatitis C, or HIV. Because whenever there will be local cases, most of the cases you are not going to perform, you are not going to screen for the viral infection like this, blood-borne viruses. Right now? Yeah, but whenever you are going to perform any elective surgery for sure, in advance, you have to get the investigations done for HIV, hepatitis B, hepatitis C. Now the question is that, out of these 4 options, what is the first step in post-exposure management? Easiest question. Obviously, you have to get first aid first, no? First aid first. After that, you can proceed for something. So first of all, you are going to wash it, right? First of all, you are going to wash it, clean it, right? So first of all, you have to do what? First aid. After that, you are, see, in every hospital, there will be a nodal center for, for this kind of injury, right now. So like after that, you are going to report to designated nodal center. When you are suspecting, whenever you are suspecting, but like whenever you'll be exposed by, you'll be very, very scared. Okay, fine. So as per the condition, you have to take the first dose of post-exposure prophylaxis for HIV. Which tablet? TLE. This is most effective. This will be most effective. See, TLE means what? Tenofovir. Tenofovir. First dose, a single tablet where you are going to see up to 300 milligram of tenofovir. There will be 300 milligram of lamivudine, and there will be 600 milligram of efavirenz. Okay, fine. So 1 tablet of TLE should be taken as the, just after the exposure. This is just like a prophylaxis for HIV. What kind of question they are going to frame? It will show maximum result or the best effect, maximum effect, when it will be taken within 2 hours. 2 hours. No effect it will be if it will be taken after 72 hours. Remember all these points. Fine. After taking the tablet, now you are going to give the sample of yours as well as of patient. You are going to, and after that, there should be what? Like investigation for blood-borne viruses like hepatitis B, C, and HIV. Fine. Okay, now after that, like the decision should be taken for HIV and hepatitis B virus after the investigation, right? And then, yes, there should be documentation and the recording of exposure. So what is happening here? So whenever you will be get injured, like in the nodal center, whenever you will go there, there will be a person sitting and he will be doing the counseling. Because see, any doctor or any person who is going to get injured, obviously you will be scared, no? Fine, no? So fine. So after that, there will be the counseling for this. Now the question is that, if you got needle prick injury, for sure you have to, for sure you are going to send the blood sample of patient for hepatitis B, hepatitis C, and HIV testing. Are you going to send the sample only of the patient or your sample also? Answer is, sample should be sent of both doctor and patient both. It could be possible that you could also be infected. No, it could be possible, right? All right. Fine. See, now related to hepatitis B virus, how you are going to take the decision. Fine. Now, suppose if you are completely vaccinated and the titer, antibody titer is more than 10. So it means you are 100% safe. No need of further treatment. No need of further treatment. If you are vaccinated and antibody titer is not 100% protective, if it is less than 10, Now you need their treatment. You have to take immunoglobulin also, and you have to take the vaccine also. Right now, vaccine also. Next question, please. A patient is brought to emergency department with history of passage of a small amounts of repeated thin stools with the mucus. Subjective feeling of fever. Fever is there, it means infection is there. With the lower abdominal pain with the leukocytes in stool. What is the answer here? See, please understand that for sure, yeah, this is the case of the infection for sure. So what is happening? A repeated thin stools with the mucus. Okay, see, I can suspect that there can be the minor. There can be the minor bleeding. A blood in stool is also there. Please understand that out of these four options, all these can cause diarrhea. All these can cause diarrhea. Fine, no? Okay, diarrhea hai. And after the infection is there, so fever is there, abdominal pain. Okay, fine. Fine. No. But out of these four options, in diarrhea, you can see blood only in 𝗵𝗵𝗄𝗃, in 𝗵𝗵 histolytica. 𝗵𝗵𝗄𝗃. Fine. No? See, remember this part. So mucoid or bloody discharge. Mucoid or bloody discharge will be seen only in 𝗵𝗵. Means 𝗵𝗵𝗄𝗃. Next question. A 70-year-old male present for the first time with complaints of dribbling of urine, frequency and hesitancy. Okay, 70-year means he is an elder. Dribbling of urine, frequency and hesitancy. On examination, his prostate is enlarged. What is the first line of management? So now you tell me, first of all, you tell me what is the diagnosis? Okay, diagnosis is what? BPH, benign prostatic hyperplasia. Diagnosis is benign prostatic hyperplasia. Okay. Now, you can give alpha blocker also. You can give 5-alpha reductase inhibitor also. Both can be given. But the question is, first line of management, he is there for the first time. First line of management. Now, do understand here that. See, this is the normal prostate. You can see the the opening of urethra. This is completely normal. But when there will be enlarged prostate, when there will be a small like this, no? I know. Hypertrophy, hyperplasia. So because of the enlarged prostate, now what is happening here? Now there is narrowing in the urethral opening. Narrowing in urethral opening. Now, see, this can see what is happening here. If I am going to give one drug, that is alpha blocker, like the prazosin or the tamsulosin. See, this is going to, whenever I'm going to give the alpha blocker, it will relax the smooth muscle. It will relax the smooth muscle. So whenever I'm giving him alpha blocker, it is going to relax the smooth muscle, and after that, a person can easily pass the urine on the spot. Like this is going to affect. But what is wrong with 5-alpha reductase like finasteride? When I talk about finasteride, which is actually a 5-alpha reductase inhibitor, right now, please understand that. See, the testosterone will be converted into dihydrotestosterone with the help of which enzyme? 5-alpha reductase. Okay, no? So whenever active form of the testosterone will be the dihydrotestosterone, which is going to work. See, because of this, now androgen will be working, right? No, androgen and all. See, what is happening here? First of all, see, because of this, what is happening, and because of this, like there will be hyperfunction of the, because of this, there will be hyperaction of the androgen and all, and this is going to work. Okay, this is going to become the reason for the BPH. Now, it could be possible that I'm going to block this enzyme. When I'm going to block this enzyme now, there will not be conversion of testosterone into dihydrotestosterone. Fine. But if I'm going to start finasteride now, it will take at least 1 month to remove all the dihydrotestosterone. It will take at least 1 month to get activated. So do you think this is a wise decision on the, okay, see, on the spot, first line of management will be what? Alpha blocker, like the tamsulosin or the prazosin, Fine. Answer will be B here. Next, a 45-year-old male presented to emergency room with massive upper GI bleed. Okay, upper GI bleed is there, upper GI bleed. On physical examination, he has mild splenomegaly in the absence of other information available. Which of the following is the most appropriate therapeutic modality for this patient? Now see, what is the most common cause of upper GI bleed? Okay, peptic ulcer disease. See here, now you don't have any information whether patient is having variceal bleeding or what, right? Okay, you don't have any information. So being a junior most doctor, how you are going to help the patient? Please understand that, okay, first of all, even if you are doing internship, you will understand that, yes, the most common cause of upper GI bleeding is what? Peptic ulcer disease, where, okay, there can be what? Okay, see, hypersecretion of hydrochloric acid. Out of these four, what should be the first line of management? Yes, you should give what? You should give a drug which is going to block hydrochloric acid secretion. You have to give a PPI. You have to give a what? PPI. You have to give a proton pump inhibitor. You have to give what? Antacid. You have to give antacid. Antacid like what? Pan-40 injection, pantoprazole. So first line of drug, better see, because you do not have complete information, because, okay, so mostly you have to suspect what most common cause is what? Peptic ulcer disease. So answer should be what? IV pantoprazole, IV pantoprazole. Easy to understand? Fine. Upper GI bleed. But when this will be 100%, see, Hannah, when, see, like even all cases, IV pantoprazole is mandatory, you have to give. But now afterwards, if you have a known case of esophageal variceal bleeding, right now, okay, fine, then you can give, okay, then at that time you can give the injection of what? Octreotide. Okay, fine. See, related to upper GI bleed, like there are two situations. One is called as the Biliary One is called as the Biliary. Second is called as the 𝗵𝗺 syndrome. Which one is more dangerous? Answer me, please. When I talk about Biliary, when I talk about 𝗵𝗺 syndrome, which one is more dangerous? See here, how to understand that whether a person like, now suppose if you have two patients, you are working in surgical emergency. Okay, you are working in surgical emergency department. You have two patients, patient A and patient B. After the consumption of alcohol, after that both had forceful vomiting, both had upper GI bleed, But patient A, he walked himself to hospital. Patient B, just after the vomiting, just after the upper GI bleeding, he collapsed on the spot. He collapsed and some other people brought him hospital. Patient who walked himself, Biliary. Patient who got collapsed, 𝗵𝗺 syndrome. Now the question is, which one is more dangerous? Obviously, 𝗵𝗺 syndrome is more dangerous. See, whenever there will be a partial longitudinal here, okay, longitudinal, but this will be only the partial tear at the cardial junction. This is Biliary. But at the lower third of esophagus here, if there will be complete perforation, complete tear. Now what is happening here? Okay, now what is happening after the vomiting? Even the food particle that can enter into mediastinum. See, there can be what? See, after that, there can be what? Severe infection of the thoracic cavity also. Now, patient can have what? Anthony, please. Upper GI bleed right now. Upper GI bleed. Upper GI bleed, and after that patient will be having what? Severe pain, and there will be what? Subcutaneous emphysema. Subcutaneous emphysema. Finally, you might have learned about macular, something called as maculars. Right? Okay, maculars. Okay, this is seen in 𝗵𝗏 syndrome. Next question, please. And African patient is presented to your clinic with complaints of severe abdominal pain, nausea and vomiting, and 4 episodes of diarrhea with bleeding. Bleeding is also there. Which of the following treatment protocol is not suitable for this patient? See here, the question is that you are getting a patient of the diarrhea. You are getting a patient of diarrhea. But diarrhea is also, along with the diarrhea, there is the bleeding. So first of all, see here. Okay, see, after the loose motion 4 episodes, a person will be dehydrated. Are you going to start him on IV fluid? Yes. Are you going to give injection of the pantoprazole and the ondansetron? Yes, because see, like he will be having what? Like abdominal pain is there, no? So you have to give one antacid, and patient is also having the vomiting, no? So you have give what? You have to give ondansetron. Yes. See here, at least you have to add one antibiotic in IV fluid, and that antibiotic you are adding what? Metronidazole. Okay, this is also fine. But are you going to start him on loperamide? Are you going to give him loperamide? Do understand that here you might be suspecting, okay, patient is African. So in your mind, something will be going on that is called as what? Traveler's diarrhea. And for this, actually, the drug of choice is loperamide. Please understand that. What is the mechanism of action of loperamide? What is the mechanism of action of loperamide? This is going to block the movement of intestine. This is going to block the movement of intestine. This is a mu receptor agonist. It will decrease the motility and secretion, and it is going to increase the tone of anal sphincter. Anal sphincter, like lock and block. If it is going to increase the pressure there in the wall. Now, patient is already having bleeding. If you are going to give him loperamide, now there will be lock and block condition. Now he will be having more bleeding. So please understand that yes, loperamide can be given for the diarrhea, but if diarrhea is having bleeding, do not give loperamide. Loperamide should never be given because it can cause more bleeding. It can cause more bleeding. Next question, spasm of internal anal sphincter causes severe pain in the given condition. Which of the following is better option to give prompt relief to the patient? Basically, this is a case of what? See, this is mentioned here. This is a case of anal fissure, right now? Anal fissure. Okay, fine. So what is the root cause of anal fissure? See here, how anal fissure will be there. What is the pathology of anal fissure? See, whenever a person will be having what? Severe constipation, or if there will be passage of hard stool, right now. So because of this, there will be high pressure, or there can be a rupture in the membrane of the, okay, there can be a rupture in the membrane of the anal there, okay, anal fissure. Okay, fine, fine. Or maybe if there will see here, like one more pathology is there, see, there will be increased pressure in the, see here, no? Here there will be high pressure. Internal anal sphincter. See, there will be high spasm. High spasm will be there. High spasm. So because of the spasmodic contraction, because of the high spasm of this part here, so what is happening here? So please understand here that, so please understand, see, whenever there will be very high spasm in the internal sphincter, fine. So what is happening here? There will be what? Ischemia, there will be blockage of blood, right now. And because of that, there will be severe pain. So now you tell me how you are going to help. You are going to help the patient by giving what? Which can relax the spasm, which can relax the spasm, which can release the pressure, like a calcium channel blocker here, right? Like a calcium channel blocker. So out of these four options, please understand here that, see here, the best is local local application. For local application, you can give a gel, 2% diltiazem gel, 2% diltiazem gel. Easy to understand. Same thing is happening. See, when I talk about upper part of GIT, okay, there is something called as 𝗙𝗃𝗂𝗃. There also, there will be what? There will be high pressure. You see, there will be what? There will be failure of relaxation in the, there will be failure of relaxation, right now. Even in 𝗙𝗃𝗂𝗃, see, there will be failure of relaxation. There will be high tone. So now you tell me what is happening here. So there also you are giving a drug, no? There also you are giving calcium channel blocker. There also you are giving what? Calcium channel blocker like nifedipine and all. Fine, no? So in the same manner here also in a case of anal fissure also you are giving what? Calcium channel blocker like 2% diltiazem gel. You are even same in 𝗙𝗃𝗂𝗃 also to release the pressure, to improve the relaxation. There also you were giving what? Botox injection with the help of endoscopy, Botox injection. Here also you are giving. Okay, no? See, in a case of the anal fissure, earlier we were performing what? Manual dilatation, which is called the Lord's procedure. Like there also in 𝗙𝗃𝗂𝗃 also we have done a type of dilatation that is called as 𝗲𝗃 dilatation. 𝗲𝗃 dilatation, which is called the balloon dilatation. Balloon dilatation in 𝗙𝗃𝗂𝗃 we have done. Here also we are going to perform, in a case of anal fissure, we are also going to perform what? Like a sphincterotomy. But the name of the procedure is called the Notaras procedure. Notaras lateral sphincterotomy. In 𝗙𝗃𝗂𝗃 also we have done a type of the tomy that was called a what? Heller's cardiomyotomy. Heller's cardiomyotomy. Heller's cardiomyotomy. So please understand that, see, the root cause is same. So if they are going to ask you first line of management, they should always be calcium channel blocker. They should always be calcium channel blocker. If they are going to ask you the final management, that will be surgery only, right? Now see this question. A 55-year-old female complains of morning stiffness in fingers, lasting longer than 30 minutes every day. On examination, swelling, tenderness, decreased range of motion, and a worm in more than one joint seen. And this is the radiological, image where you can see what? Erosions and all. Fine. Doctors suggested 𝗲𝗪. See, what is the full form of 𝗲𝗪? 𝗲𝗪, disease modifying anti-rheumatoid drugs. So basically overall, as per the radiological image and the clinical condition, you can easily say that patient is suffering from rheumatoid arthritis. Rheumatoid arthritis. Now, doctor is already going to start on 𝗲𝗪, like methotrexate and all. Fine, no? Like so many drugs are there in that group. Fine. Okay, fine. So now do understand that before you are going to start a patient on 𝗲𝗪, which investigation should be done in advance? As we all know that 𝗲𝗪 is having hepatotoxicity. Hepatotoxicity. So when we already know that 𝗲𝗪 is having hepatotoxicity, first of all, we have to perform one blood investigation that is called as what? Liver function test. Easy to understand? So whenever you are learning pharmacology, please remember all types of side effects. If you know these side effects, you will understand which blood investigation is mandatory to perform in advance. Suppose if a drug like metformin is there, for metformin, okay, see metformin like a renal problem will be there. Fine, no? Or whenever there will be renal insufficiency, you should never start a patient on metformin for diabetes, right? No, fine, no. So in that condition, for sure, you have to do KFT, right? Easy to understand? Fine. Very good. So in this case, answer will be what? Liver function test. Next question. A patient gets fulminant hepatic failure due to acetaminophen poisoning. This is also called the paracetamol poisoning, which is causing what? Hepatotoxicity. Which of the following is the treatment of choice? Now, most of you are marking what? N-acetylcysteine, right? See here. Whenever there will be paracetamol poisoning, first of all, how much is the toxic dose of paracetamol? 10 gram. Or some books are also writing approximately 12 gram. So how many tablets of paracetamol will be injurious to a person? Equal to a more than 20 tablets, right? Yeah, because most of the paracetamol, medicine, like if I talk about Dolo or Dolo 500 BA, 650 BA, but mostly like they will be of 500 milligram. So if you are going to calculate it, like it should be like more than 20 tablets. So like if a person has consumed more than 18 to 20 tablets of the paracetamol, yes, he is at the higher risk of paracetamol poisoning. As we all know that antidote of paracetamol poisoning is N-acetylcysteine. Okay, fine. N-acetylcysteine. So whenever you are receiving the patient, you have to start with the administration of N-acetylcysteine along with charcoal. If patient is improving or if you can see there is more deterioration in these symptoms. After that, if patient is not going to improve, he will be having what? Fulminant hepatic failure. Fulminant hepatic failure means now N-acetylcysteine will not be of any use. Patient is having what? Fulminant hepatic failure here. Now last option, you have only one option: liver transplantation. So the final management for the fulminant hepatic failure due to paracetamol poisoning is what? Liver transplantation. Liver transplantation. Always understand how you are going to manage the patient of paracetamol poisoning. First of all, charcoal along with N-acetylcysteine. If there is no response, it means after that there will be what? Fulminant hepatic failure. Now last option, you have what? Emergency liver transplantation. Liver transplantation. If I ask you one question, please tell me what is the most common indication of liver transplantation in adults? Most common indication of liver transplantation in adults. What is your answer? Adults में क्या बताओ? Cirrhosis, right? Cirrhosis. What is the most common cause of liver? What is the most common indication of liver transplantation in the pediatric age group? It is the biliary atresia. Biliary atresia. What is the most common indication of liver transplantation in acute condition? In acute condition, it is the paracetamol poisoning. PCM poisoning. PCM poisoning. Next question. One night before an elective cholecystectomy, patient is scared, anxious, and not getting sleep. Obviously, any patient who is admitted in your department who knows that in early morning one blade is going to open his abdomen, and he will also be under general anesthesia. So he will be thinking after the anesthesia whether I will get up or not. A blade is going to open my abdomen. For sure, he will be having anxiety, right? He may not be able to sleep. how you are going to help the patient. Are you going to give high dose of diazepam IV so that he should sleep as soon as possible? Why high dose? No, see, this anxiety is pretty common. It will be there for sure. So one night before, okay, minor dose 0.25 milligram of alprazolam can be given. So see here, no, this is a type of benzodiazepine. This is a type of benzodiazepine, alprazolam, right? Alprax. Minimum dose is 0.25 milligram. Minimum 0.25 milligram. So see, this has hypnotic effect as well as sedative effect. Patient can sleep also, and in early morning when he will get up, he will not be having any anxiety. So if you give 7 hours proper sleep to your patient, healing power will be good. So option C is better. A 49-year-old diabetic and hypertensive patient taking several drugs presented with septicemia. Diabetic and hypertension both, hypertensive. So like like the patient is having medicine for diabetes, also for hypertension also. So he is taking multiple drugs. Now he is having septicemia. When renal function test was done, when kidney function test was done, see, this was the level of creatinine, which is very, 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 very high, which shows what? Renal insufficiency. Which of the following drugs should be stopped? Out of these 4, patient is on all these drugs. See, linagliptin, this is safe in your renal failure, but okay, side effect of linagliptin is what? Acute pancreatitis, right? Okay, fine. So now you tell me here, out of these drugs, which drug should be stopped if there will be a condition of renal insufficiency? Metformin, metformin, metformin. So if you want to start a patient on metformin, which is one of the most important drugs for diabetes mellitus, you have to check kidney function test. Fine. Next, Mr. Shyam has to go to Delhi next day morning by car. He has history of dizziness, lightheadedness, and nausea, vomiting while on the road. Which of the following medication can help in reducing his symptoms? So what is the diagnosis here? Overall, what is the diagnosis? Easy question, no? Motion sickness. So basically, this is a case of motion sickness. So out of these 4 options, which medicine will help your patient? Fine, no? Motion sickness ke liye, which medicine will be here? Yes, scopolamine patch, right? No, scopolamine patch, scopolamine, hyoscine, right? Scopolamine. See, this is a type of what? This is scopolamine is what? Muscarinic antagonist, right? A muscarinic antagonist. So like even you can give orally also, or you can see intradermal also you can give. Fine. So whenever we are going to give intradermal patch, this is called a what? Transderm scope. So this is very, very effective like this. He can apply here. He can apply here. This is what? This is scopolamine. This is what? This is for motion sickness disorder. Next. An obese diabetic woman has on failed metformin therapy. She has history of pancreatitis, family history of bladder cancer. She is not willing to take injection. Which of the following drugs should be suitable to decrease her glucose level? See, she was on metformin, but metformin failed, no use. Now, the question is, out of these 4 medicines, we have to understand which medicine is having renal problem, pancreatitis problem, and some other problems as per the given clinical condition. See, sitagliptin, side effect of gliptins are what? Side effect is what? Acute pancreatitis. So it should not be given. Okay, fine. Now there is a drug that is called a pioglitazone. If you give this drug, then patient is having higher risk of development of bladder cancer in future. Bladder cancer in future. So this is called a dangerous drug. So whenever this drug will be given to any patient, this drug will come with black box warning, black box warning, black box warning. Now, so like sitagliptin cannot be given, pioglitazone cannot be given. Now, out of B and C, liraglutide is given subcutaneously, and my patient doesn't want to take any injection, so I should not give liraglutide. Now we are left with SGLT. See here, no, we are left with flozin tablets. Glieflozin. See, this can be given orally also, and this can see here, like she was obese patient, so this will decrease the weight also. Fine. So please understand that. So this is actually what? SG, sodium glucose linked transport 2 inhibitor, SGLT 2 inhibitors, canagliflozin, dapagliflozin, empagliflozin. Fine. See, this will reduce, see here, this will reduce BP, this will reduce uric acid, and this will reduce weight also, right? So for my patient, out of these 4 drugs, best option is SGLT2 inhibitors, canagliflozin. In this manner, they will ask you the question. Next, which of the following is the most appropriate instruction to be given to a lactating mother regarding drug use? When a mother is lactating, when she is feeding her baby. Now see, when she is on the drug, yes, after the lactation, yes, baby can also have, right? Baby can also get the drug, which, okay, like there, we should like stop the baby from the exposure of the drug, right now. So what should be the best instruction? Best instruction, yes, she can take the medicine, but she should feed the baby at a time when baby will have least exposure to drugs. So what should be the best instruction here? Out of these 4 instructions, feed the baby just before next dose. Suppose if she was taking a medicine BD means what? At the interval of 12 hours. 1 tablet she used to take at 9 a.m. Second tablet she used to take at 9 p.m. So this is really better if she can feed at 8:30 a.m. or 8:30 p.m. just before, or 8:45, whatever. So just before the next dose, so that whenever she is going to take the medicine, there should be the proper metabolism of the medicine, right? A 70-year-old male has difficulty in urination associated with increased urge and frequency. He has to get up several times in night to relieve himself. There is no history of any burning micturition and lower back pain. On a rectal examination, he has enlarged prostate. So basically, this is a case of what? Up to this point, this is a case of BPH, benign prostatic hyperplasia, and most of the students will not read the last line, and they will mark the pathology question, the general pathology question, that this is a case of hyperplasia, right? I'm sure most of you might have marked hyperplasia answer because you have diagnosed the case easily. This is the case of benign prostatic hyperplasia, so you have marked hyperplasia, but you did not read the last line. Which of the following represents the most likely change in the bladder? Examiner is not asking about prostate gland. ये तो question में था ही नहीं. Examiner is asking about bladder. This is the bladder, and this is the prostate gland. This is the urethra. So whenever, so please understand that whenever there will be benign prostatic hyperplasia, bladder has to work hard. Bladder has to work hard Bladder has to work hard to release the urine. I'm talking about bladder. So there will be hypertrophy here. Answer is hypertrophy. Because bladder has to work against resistance. Whenever you are working in gym, whenever you are doing the exercise for the biceps, what is happening? Your biceps is working against the resistance. Fine. No. So and after that, there is happening what? There will be what? Hypertrophy. Now see here, 𝗂𝗀𝗃 disease is a disorder where an affected child has peculiar white stubby hair, does not grow, brain degeneration is seen, and dies by age of 2 years. Okay, fine. So as per the pathology, we are understanding it. Mrs. A is hesitant about having children because her 2 sisters had sons who died from the same disease. Her mother's brother also died of the same condition. Which of the following is a possible mode of inheritance in her family? Now you understand here that since only males are dying, only males are dying. So I can say this is sex-linked disorder. So here I can say what? Inheritance is what? Sex-linked. So option A or B will be there. C and D are gone. Now the question is that, see here, male have only one X chromosome. Only one X chromosome. Female has 2. So whenever male will be affected, for sure, he is going to present the disease. He will be affected, and for sure, he will be having all the presentation. Fine. But since female has 2 X chromosome, even if one is affected, second is not affected, she can phonetically be normal, but she will be considered as a carrier. But if she is going to present everything, then this would have become what? Then this would have become the dominant. Fine. Now, since what is happening here in this condition, females are only the carriers. They are not presenting the disease. They are not manifesting the disease. Only males are having the manifestations. Fine. Now, so this is the case of what? X-linked recessive. X-linked recessive. Next, a young boy is presented to emergency with complaints of red rashes over body and difficulty in breathing. He gives history of having food at hostel. Which type of hypersensitivity reaction is this? See, this is the question of general pathology only. So basically, he had what? Food allergy. Food allergy. Any kind of allergy like food allergy, or see here, or if a person is having what? Atopic dermatitis and all. Fine. No. So this is, so any kind of allergy, this kind of food allergy, this is a type of what? Type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction, where a person is having what? Anaphylaxis right now. Anaphylaxis. Fine. So when I talk about type 1 anaphylaxis, okay, this is a type of anaphylactic type. Fine. Now, when I talk about type 2, this is antibody mediated. Immune complex formation will be there in type 3. Cell mediated will be type 4. Fine. So as per the clinical condition, you can easily understand that, yes, this is a case of food allergy. Food allergy means type 1 hypersensitivity reaction, which is also called as what? Anaphylactic type. Anaphylactic type. Next, endoscopic findings of lower esophagus is shown here, where in response to GERD, GERD means what? Gastroesophageal reflux disease. Reflux disease. Fine. Now, gastroesophageal reflux disease. A type of epithelium is replaced by another epithelium at the distal part of esophagus. So what is the normal epithelium in the esophagus? In the esophagus, you are having what? A squamous epithelium. I know. So when you see this picture, you can see what? Red velvety epithelium. Fine. red velvety epithelium, right? Easily you can understand red velvety epithelium. So basically what is happening here? See, squamous epithelium is replaced by columnar epithelium. As per this situation, you can understand in response to GERD, there will be what? There will be Barrett's esophagus. There will be Barrett's esophagus. Barrett's esophagus. This is a case of Barrett's esophagus. This is a case of cellular adaptation. This is where one type of healthy epithelium will be replaced by another type of healthy epithelium. So in a case of Barrett esophagus, squamous epithelium is replaced by columnar epithelium. Columnar epithelium. So this is called a what? Columnar metaplasia. Columnar metaplasia. So this is a type of what? Metaplasia. Easy to understand? Fine. See, related to Barrett's esophagus and 𝗙𝗫𝗂𝗃𝗃, repeatedly asked question. See here. See, now in the beginning, first of all, see here. Up to the metaplasia, okay, this is a reversible condition. But now when it is going to be turned, okay, when it is going to be progressed to dysplasia, now it will be difficult, right? Now, so in future, see what is happening here. In future, this can give rise to a carcinoma of esophagus also. So the question is that Barrett esophagus will give rise to which type of carcinoma of esophagus? Squamous cell cancer or adenocarcinoma? Barrett esophagus, batao answer. Barrett esophagus will give rise to adenocarcinoma. Adenocarcinoma. Okay, no? Adenocarcinoma. Repeatedly asked question. Barrett's esophagus will give rise to adenocarcinoma. Fine. Now, next, a female is suffering from an autoimmune disease. She does not get secretion from the organs as shown. One is eye, second is the tongue. So basically here. So it means what? So like she is suffering from a disease. This is also a type of pathology question only. I'm telling you, this is a clinical pathology question. So basically, see, this is a type of autoimmune disease. Because of that, there will be destruction of lacrimal gland and salivary gland. Lacrimal gland, no tear, no tear. No secretion, no saliva, no secretion. Where we have seen, so in which disease we have seen destruction of lacrimal glands, okay, lacrimal glands and the salivary glands. Which disease? Sjogren syndrome, Sjogren syndrome, Sjogren syndrome. So I hope all of you know that Sjogren syndrome is a type of autoimmune, right? Autoimmune disorder where which antibody will play the role? ROLA, right? Now, anti-ribonuclear antibodies. Anti-ribonuclear antibodies. SSA or SSB. ROLA. Repeatedly asked question. ROLA is responsible for which autoimmune disorder? Okay, now this is Sjogren syndrome. Sjogren syndrome. What about anti-nuclear antibody? SLE. What about anti-DNA topoisomerase antibodies? Okay, diffuse scleroderma, anti-centromere. This is for, see, limited scleroderma and diffuse scleroderma. Please remember all these points. Sometimes if they are going to ask you a one-liner question, they can ask you a question related to antibody. They can ask you a question related to autoantibody. So in Sjogren syndrome, which antibodies? Anti-ribonucleoprotein antibodies like SSA and B. Next. See, now see this condition here and answer me. Due to breakdown of communication between nerves and muscles, there is weakness. And ocular problem, which you can see in this photo. Which human leukocyte antigen is which HLA is associated with this condition? First of all, you tell me what is the diagnosis? Yeah, this is a case of the myasthenia gravis. No, out of these four, which HLA is associated with myasthenia gravis? See here. If I talk about HLA-B51, this is associated with the Behçet's disease, right? Behçet's. Okay. If I talk about HLA-B47, this is associated with congenital adrenal hyperplasia. If I talk about HLA-B27, it is associated with psoriatic arthritis, ankylosing spondylitis, right? Inflammatory bowel disease related arthritis and Reiter's syndrome. HLA-B27. So with the myasthenia gravis, which HLA is associated? HLA-B8. Answer is C. HLA-B8. HLA-B8. Next question. A 35-year-old female is suffering from a motor disorder of esophagus where she has substernal chest pain and dysphagia. So dysphagia is there. I can understand this is a case of motility disorder. Okay. Due to repetitive simultaneous non-peristaltic contraction, here we are going to discuss physiology also, pathology also. Radiological appearance on barium swallow is given here. Okay. So when you see this is something like what? Rosary bead appearance, or you can say what? Corkscrew. This is also a type of what? A rosary bead appearance, no? See, this is a very, very famous question. So as per the radiological image and clinical condition, I can say that patient is suffering from diffuse esophageal spasm, right? Diffuse esophageal spasm. Okay. Now the question is, which one is right? Which one is wrong? Which of the following is incorrect? She is suffering from diffuse esophageal spasm. Yes. Manometry for the C, always remember that for motility disorder, manometry is the most important investigation. Manometry. Fine, no? Fine. Now let's understand some more. Cases here. See here, when I talk about esophagus, see, this is esophagus. So when I talk about the peristaltic movement, what is the meaning of the peristalsis? Whenever you are going to eat anything, whenever you are going to swallow anything, right? After that, there will be peristaltic, there will be peristaltic movement in the esophagus, and after that, food will enter into the stomach. So there will be what? Peristaltic contraction, right? It can be, see here, in esophagus, there can be a primary contraction, there can be secondary contraction, and there can be the tertiary contraction. Whenever you are going to swallow anything, you eat anything, because of that, after that there will be the peristaltic movement for sure. This is fine. Okay. Okay. So this is called as the first part here, right? After swallowing anything, this is called as and there will be what? There will be peristaltic movement. And this will be, yeah, this will be the progressive also. But after the completion of your food, whenever you have finished your food, but now some food particles will get stick over the esophageal wall. So because of that, there will be irritation. Because of the irritation. If there will be peristaltic contraction, this will be considered as secondary. This will also be peristaltic. This will also be the progressive, but without anything. If it will be non-peristaltic and non-progressive. If there will be non-peristaltic esophageal contraction, if there will be non-progressive esophageal contraction, this is a type of tertiary esophageal contraction. This will be seen in diffuse esophageal spasm. Diffuse esophageal spasm. Do understand that. So see here. So when option number C here, do we see primary contraction there? No, this is wrong here. This is wrong here. There will be tertiary contraction. Now the question is that why there is diffuse esophageal spasm? See the blood supply, see esophagus does not have its own blood supply. This is a type of the parasite organ. This is going to take the blood of nearby organs. And this will be in this direction. Okay, fine. So whenever there will be non-peristaltic contraction, there will be sudden spasm. There will be sudden spasm of these blood vessels, and because of that, there will be ischemia. There will be severe substernal chest pain here. Okay, now severe substernal chest pain, and this will mimic like angina. This will mimic like angina after the emotional stress and all. If there will be what? If there will be substernal chest pain with dysphagia, this is the case of diffuse esophageal spasm. So when I talk about emotional response, yes, this will be more common among female than male. So when there is a spasm, what should be the first line of management? Always it should be medication like calcium channel blocker. If patient is not responding to medicine, then last will be what? Surgical. Fine. So here, mainstay of the management is pharmacological. Yes. Out of these four options, right? So which one is the right answer here? Fine. So option number C, as per the clinical condition, option number C is wrong, related to diffuse esophageal spasm. During the surgery of patella fracture, a tourniquet was applied over thigh. Junior doctor forgot to remove the tourniquet after completion of surgery. Patient is shifted to ward. After 6 hours of surgery, patient complained of severe pain in thigh. Nurse found that there was a tourniquet applied. She removed it and patient went into coma in next few hours. See, suppose if you are working in orthopedics department and if you are the junior doctor, whenever you will be assisting your senior surgeons. So see, in most of these surgeries, we have to apply a tourniquet. So what is the function of the application of the tourniquet? What is the meaning of the tourniquet? If you are, so suppose if I have to operate over here. So whenever I'm going to give the incision, whenever I'm going to open it, after that there will be severe bleeding, no? So when there will be severe bleeding, this will be very, very difficult for me to operate the patient, right now. No, this will be very, very difficult for me to operate the patient while there is so much pooling of blood. So I'm going to apply a tourniquet here. I'm going to apply a tourniquet here, है ना? जो एक wrap कर दूंगा, जोर से बांधो, apply करूंगा कि यहाँ पे. Okay, fine. So when I'm going to apply a tourniquet, after that there will be what? Lack of blood supply. So whenever I'm going to open it, after that there will not be severe bleeding. You will not have what? Pooling of blood. So this is the function of the tourniquet. So in this condition, there was the case of the patella fracture. A tourniquet was applied over the thigh. Fine. So what was the purpose of the application of the tourniquet? To stop the blood flow. Okay, fine. So basically you are stopping arterial blood flow, oxygenated blood flow. Okay, fine. After this surgery, this is the duty of junior doctors, okay, to junior doctors to do, okay, to remove the extra materials there. Like these things are the work of, see, like these are the responsibilities of junior doctor only. Overall, junior doctors are supposed to remove the tourniquet before shifting the patient to ward after the dressing, right? Okay, but junior doctor forgot. After 6 hours, patient had what? Severe pain in thigh. Now you tell me, 6 hours, You wanted to stop arterial blood flow, but do you think that you also have stopped venous blood flow? For 6 hours, you have stopped the blood flow. Ischemia time, right? So there is no nutrition to the affected, all the tissues which are stopped there. Fine now. And now when you have stopped venous blood flow, no, venous blood flow will be having what? Deoxygenated blood. And all the toxins will be there only, no. So where you have applied the tourniquet, obviously their oxygenated blood is also stopped, and deoxygenated, contaminated blood is also stopped. Contaminated blood. Find contaminated blood. Because of the contaminated blood, what is happening there? See, like in the nearby where you have stopped, obviously there will be what? There will be muscle injury. And what is happening here? When nurse removed it, now don't you think there will be sudden inrush of contaminated blood also in the systemic blood circulation now? Now you tell me. So after this, now I hope you can easily understand that yes, there can be toxic reaction due to quick release of the contaminated blood. Fine. So yes, after that, do you think there can be embolism and all? Do you think there can be a rupture of the muscle cells and all? There can be damage of muscle cells. There can be rhabdomyolysis, and patient can go into septic shock. I know. So like, see, even after this thing, like even there can be renal shutdown. You can lose the patient. Fine. So out of all these 4 options, see, all are right. This is known as the tourniquet syndrome, right? How to treat this case? Suppose if any doctor is doing this mistake, if he forgot to remove the tourniquet, how to treat now? Are you going to remove it abruptly? No, you are not going to remove it. Only one option you are left with. You have to do what? Just above the tourniquet, you are going to do what? Amputation. Amputation. Last option. Next question. Post-mortem of a burn case is done. Curling ulcer is found in a stomach. Which of the following is the pathophysiology for development of this ulcer? As all of you know that curling ulcer, this is a type of what? Stress ulcer. You might have learned in your general surgery. This is there are 2 types of acute stress ulcer. Acute stress ulcer, 2. One is called as the curling ulcer. Second is called as Cushing's ulcer. Cushing's ulcer. Curling ulcer you are going to see in a case of burns. Cushing's ulcer you are going to see in a case of head injury. In a case of head injury. Fine. So see here. Do you understand when I talk about head injury? When I talk about head injury. After that, there will be hypersecretion of hydrochloric acid. After that, there will be hypersecretion of hydrochloric acid. Because of this, patient will be having what? Gastric ulcer. Stress. This is a type of what? Stress gastric ulcer. Stress ulcer. Fine. So because of hypersecretion of hydrochloric acid. So what is the most common location? See, where you are going to see the maximum concentration of hydrochloric acid secreting cells. So now you answer me physiology question. Which cells secrete hydrochloric acid? Hydrochloric acid will be secreted by the parietal cells. Most common location, fundus, then body, then antrum, and then pylorus. Common location of stress ulcer is fundus, then body, then antrum, and then the pylorus. After that, you can D1 or D2. Okay, fine. So when I talk about Cushing's ulcer, yes, head injury. After that, there will be hypersecretion of acid. Okay, that is the reason for the formation of Cushing ulcer. But what about curling ulcer? I do understand that in a case of burns, there will not be hypersecretion of acid. Hydrochloric acid will be either normal or it will be decreased. But why there is formation of burns? Because there will be damage of mucosal defense. There will be damage of mucosal defense in GIT. So answer will be what? Decreased mucosal defense in GIT. GIT. This is the reason for formation of curling ulcer in burns. Do understand? In curling ulcer in burns, hydrochloric acid secretion will be normal or decreased. A patient of asthma is on corticosteroid therapy. Following the therapy, blood sample is taken. Levels of all circulating blood cells will be increased. If you are getting a patient of COVID-19, and now if you have to start the patient on a steroid, if you have to start a patient on a steroid, right now, as all of you know that, like after a steroid application, there will be hyperglycemia. So there are so many effects of the steroid, like in our body. Steroid also have effects on our blood cells. We have to anticipate that if a patient is on a steroid, there will be a fluctuation in different blood cells. I'm asking you, levels of all circulating blood cells will be increased except. Do remember, see here, when I talk about a steroid, when I talk about cortisol, this stimulates 𝗵𝗵𝗄𝗃𝗃, means blood formation. So there will be increase of PEN. There will be increase of platelet, erythrocytes, and neutrophils. But the steroid also decreases the number of circulating bile. You remember 1 pen and 1 bile. Increase of pen, platelets, erythrocytes, and neutrophils. But there will be decrease of what? Basophils, eosinophils, and lymphocytes. So what is the answer here? Bile, right? Decreasing eosinophils. Next question, please. A person in gym is doing rigorous exercises. Which of the following is a right physiology in this condition? See here, when you are working in gym, for sure, skeletal muscles and skeletal muscles need more blood supply. So there will be increased level of blood supply. So this is wrong. Okay. Fine now? Fine. But what about, see here? See, what about brain, or what about GIT and liver? See, like during the exercise, GIT part of the liver, they do not need that much blood. So even if it is going to decrease, it will be fine. Now do understand here that during exercise, blood will be increased in skeletal muscles. First of all, skeletal muscles. And obviously, heart needs more blood so that it can pump the more blood at the time. So like there will be increase of the coronary circulation. Okay, fine. And at that time, you will be breathing very, very fast. So lungs also need blood. Blood flow will be increased in skeletal muscles, heart, and lungs. It will be decreased where there is not so much requirement, like liver and GIT, renal part also, or inactive skeletal muscles. No alteration, unaltered in brain, unaltered in brain. So out of these four, which one is a right physiology, right? Blood supply is increased in coronary circulation. Next question, if the rectum is inflated with gas, rectum, while doing sigmoidoscopy, increased peristalsis is seen in which part of the intestine? See, if you know the basic anatomy of colon of large intestine, see, this part is called as cecum. This is ascending colon, and this is transverse colon, and this is descending colon. This is sigmoid colon. This is, and this is rectum, and after that lowermost part is the anal canal. Fine. So whenever you are going to do sigmoidoscopy, means you are going to insert one apparatus up to here right now. Okay, fine. So do understand that, see, this is a type of, see, whenever anything is going to, see what is happening here, when any foreign object is going to obstruct, or it is going to irritate any part, see, like there will be the peristaltic movement, there will be hypersecretion, and after that patient will be having the, a person will be having the the diarrhea, or you can say defecation, right? Now defecation. Fine. Okay, fine. So defecation means, so this is a type of what? This is a type of defecation reflex. Defecation reflex. So now you tell me, whenever you are going to perform sigmoidoscopy, now see, this part is called as, the proximal part of large intestine, and up to this part, this is called a what? Distal part, right? Now distal part, right? Now, so now you tell me, whenever you are going to perform sigmoidoscopy, okay, wall of which part of the colon will be irritated? Now you tell me, distal colon or the proximal colon? Obviously distal, right? Now, so this is a type of defecation reflex. Defecation reflex. Answer is what? Distal colon. Distal colon. Now, how much pressure is required so that there will be urge of defecation? The urge to defecate is first felt when a rectal pressure will be increasing, when a rectal pressure will be around 18 millimeter of mercury. Okay, now you tell me, how much is the length of different types of instrument which we are using in the like in the lower GI part? See, whenever I have to use, suppose if I have to do the investigation, if I have to do the examination of only anal canal, okay, no, fine, or the beginning part of the rectum, right? Now, because see, like anal canal, like 4 centimeter, and the rectum up to 12 centimeter. Fine. No. So whenever I'm using only a proctoscope, see, this can go up to 8 centimeter only. Rigid sigmoidoscope only 20, flexible more inside 60 centimeter, colonoscope 160 centimeter. Next question. A father is standing near a doctor who is doing the dressing for a cut injury to his 5-year-old son. While watching the bleeding out of raw wound, father fell down. What can be the reason here? So basically, after sight of blood, father fainted. Faint matlab behosh ho jana. See, please understand that. So this is a type of what? This is a type of syncope, right? This is a type of syncope. Which type of syncope? See, different types of syncope is there. Different types of syncope. Even when you were in the first year or second year, whenever, you know, like during the experiment, during the physiology lab or pharma lab, okay, whenever like your professor might have done some kind of experiment where you might have seen the blood. I know. So in the beginning, some students will be having hemophobia. Hemophobia means what? Hemophobia, fear of blood. Hemophobia, fear of blood. Okay, fine. So after sight of blood, a person can faint. A student can faint. This is a type of syncope. So what is happening here? See, do understand there are different types of syncope: vasovagal, carotid, sinus, and situational. See here, whenever in response to, see here, like in response to stressful stimuli. Okay, whenever like there will be sudden drop in blood pressure. Whenever there will be sudden drop in blood pressure. And because of this, what is happening is, say, whenever there will be any emotional stress, or if a person is standing for the longer time, or if there will be any kind of, you know, like sight of blood, fine, when your body is not able to respond. Now, what is happening here? Whenever, because of this stressful stimuli, if there will be sudden fall in blood pressure, after that, your heart will do what? See, right, so what is happening here? After that, your heart will pump less blood, right? Less blood. And after the person is going to faint. This is called as vasovagal syncope. How to treat? है ना? कभी injection देते अगर गिर गया तुम्हारा कोई दोस्त, कैसे उसको ये करोगे? Okay, just elevate the lower limbs. So that you can shift the blood circulation from lower limbs to the upper part, so that there should be increased flow of blood to the brain. Okay, no, brain. This is a type of what? Vasovagal syncope. Or whenever you are going to apply a tight collar or any kind of bandage here, if there will be pressure over the carotid artery, right now? Fine. See, and after that, there will be lack of blood supply. You can faint. This is called the carotid sinus syncope. Carotid sinus syncope. Okay, some in some different situation, like like during the time of a strain. Okay, suppose like if you are having GIT problem and all, or maybe like if there will be, so because of the high strain, if there will be blockage of the like the blood supply, situational syncope. So as per this clinical condition, yes, this is a case of what? Vasovagal syncope, site of blood, sudden drop in blood pressure. See, next, as a part of a space research program, a physiologist was asked to investigate the effect of flight-induced stress on blood pressure. Accordingly, blood pressure of the cosmonauts were to be measured twice. One before the takeoff and once after the spacecraft entered the designated orbit around the Earth. For a proper comparison, the pre-flight blood pressure should be recorded in. Pre-flight blood pressure should be recorded in which position? Sitting position, standing position, or lying down position. Please understand that in zero gravity, suppose if an astronaut, when he has entered in this space, so in zero gravity, blood will become weightless. Blood will become what? Weightless. So now if a person, so it will take same time in the standing position to the lying position. See, please understand that. See, this can, so what is happening in the zero gravity, what is happening here? Blood will reach to the brain as easy as it is going to reach the lower limbs. So you may not have the equal distribution like of the circulatory part here. Easy to understand now? Fine now? So see here, now in which position you are going to have the balanced blood, balanced in a lying position there, not in the standing position, not in the sitting position, but in the lying position where there will be equal distribution of the blood. And at that time, you will be having what? You will be having perfect measurement of blood, BP, blood pressure, right? So in lying down position. Next, after a building catches on fire, a pulseless body recovered from the building after a few hours. Body was taken to hospital for post-mortem examination, and presentation of body was similar to the given photos. In this question, forensic medicine, like see in this question, there is integration of the forensic and physiology. Respiratory physiology. See here, first of all, when I see the post-mortem staining, or the hypostasis, see what is the discoloration here? What is it a purple blue? No, this is a type of what? Cherry red color. Where we have seen this type of staining? Yes, in a type of CO poisoning, carbon monoxide poisoning, easy to understand. See, even as per the clinical condition, yes, this is the case when a building had the fire. Fine, no? So what is happening here? Whenever there will be when a person is going to inhale so much smoke, right? Smoke. So there will be what? See, there will be inhalation of carbon monoxide, right? No, carbon monoxide. So yes, this is a case of carbon monoxide poisoning for sure. Now the question what examiner is asking, which type of hypoxia could have caused his death? See, we have learned in respiratory physiology, there is a type of hypoxia that is called anemic. And after that, anemic, and then answer me please. Yeah, hypoperfusion, or if there will be what? Histotoxic type of hypoxia. Fine. Anemic hypoxia, hypoperfusion type, which is also called as what? Stagnant. No, stagnant, right? Okay. And one is called as hypoxic hypoxia. Hypoxic hypoxia. So there are 4 types of hypoxia which we have learned in respiratory physiology. See what is happening here. When I talk about hypoxic hypoxia, means there is lack of oxygen. There is lack of oxygen. Because of that, there is what? Hypoxia. But when I talk about anemic hypoxia, what is happening here? In anemic hypoxia, anemia means what? Lack of lack of hemoglobin. Okay. What is happening here? Whenever there will be CO poisoning, no. When a person is normal, there will be what? Oxyhemoglobin. Whenever there will be inhalation of carbon monoxide. Now you tell me, which one is having more affinity for hemoglobin, oxygen or carbon monoxide? Carbon monoxide is having maximum affinity for hemoglobin, much more than oxygen. So when carbon monoxide is there in the blood, now it is going to take hemoglobin away. Oxygen is there, but now hemoglobin is not. Now the oxygen carrying capacity is decreased here. So now, see, situation will be similar to anemic hypoxia. Anemic hypoxia. So when I talk about CO poisoning will cause anemic hypoxia. Anemic hypoxia. But what is happening here? Suppose if there will be cyanide poisoning, no, cyanide poisoning. Cyanide poisoning is going to block which enzyme? Cytochrome oxidase enzyme. Cytochrome oxidase enzyme. Okay, this is going to block which complex of ETC? 4th complex, right? Now, 4th complex. Now, what is happening here? Whenever there will be blockage of cytochrome oxidase, after that, tissues will not be able to use the available oxygen. Oxygen is there, but tissues are not able to use it. So that's why even in cyanide poisoning also, there will be brick red color, or you can say bright red color. Brick red color staining will be there. Fine. No? Oxygen is there, but tissues are not able to use the oxygen. So cyanide poisoning, histotoxic hypoxia. CO poisoning, anemic hypoxia. Answer will be B, anemic hypoxia. Next, after an RTA, a person suffered severe head injury. All of the hormones will be affected except prolactin, vasopressin, adrenocorticotropic hormone. What about somatostatin? Somatostatin will be released by which organ? Somatostatin. Easy to understand, no? Which cells of the pancreas? D cells. Alpha cells, glucagon, right? Beta cells, insulin. D cell, delta cells, somatostatin. So what is happening in head injury is there? Somatostatin is produced by the pancreas. So this will not be affected here. So ABC, prolactin, vasopressin, adrenocorticotropic hormone, all these are produced by, see here, no? Like the pituitary gland only, no? But somatostatin, which is produced by, okay, delta cells of pancreas. So C will not be affected. 55-year-old male, follow-up case of COVID-19, presents with shortness of breath during exercise, dry cough, tiredness, and joint pain. His radiological images are shown below. Which of the following is right about this condition? See, actually, he is a follow-up case of the COVID-19. As all of you know that, see here, as per the radiological, images, yes, see the white part here, no? Right? So what is this? So all these are what? Something like a small word, scarring and fibrosis type, no? This is a case of what? This is the case of pulmonary fibrosis. This is the case of the pulmonary fibrosis. So here examiner has integrated radiology, physiology, and the medicine. But the question is being asked on physiology. Okay, fine. So now you tell me, so pulmonary fibrosis is a type of obstructive lung disease or restrictive lung disease. Obstructive or restrictive lung disease. What is the meaning of obstructive and restrictive? In obstructive lung disease, inhalation is normal. Inhalation is normal. Breathing in is normal, but there will be problem in alveoli deflation. Alveoli is not able to deflate normally. Problem in expiration. Inhalation is normal, no problem at all, no problem at all. I can inhale easily, but alveoli are not able to deflate normally. Expiration is problem. So now inhalation is normal. So I can say total lung capacity will be increased only. After that, residual volume will be increased for sure. Easy to understand, no? So I can say what? See here, even total lung capacity, residual volume, functional residual capacity. But when I have problem in expiration, then first expiratory volume in first second, this will be decreased. And the ratio of this will also be decreased. So this is about obstructive lung disease. What about restrictive lung disease? Restrictive lung disease. See where because of the fibrosis, because of the scarring over a lung parenchyma, when I'm not able to inhale normally, inhalation is problem. Alveoli can deflate easily, but inhalation is problem. So breathing in is restricted. This is called a what? Restrictive lung disease. So now here, total lung capacity will be decreased. Residual volume for all these are going to be decreased, but this ratio will be normal or increased. So when I talk about emphysema, bronchitis, asthma, COPD, and all these are what? These are type of what? Obstructive lung disease. But when I talk about interstitial lung diseases like pneumoconiosis and all, when I talk about pulmonary fibrosis, these are type of what? Restrictive lung disease. So basically in this question, I'm asking you the right physiology related to restrictive lung disease. Only ratio is getting normal or increase. So answer will be what? C here. Right? Next, a 25-year-old female presents with complaints of dysphagia, means problem in swelling. For water is more than food. Following image is seen on barium silo. Okay. Very, see here, no? Repeatedly asked question. This image is frequently asked in all exams. This is a type of what? Bird beak appearance, right now? Bird beak appearance. Where do we see? Dysphagia is also there. We see in 𝗙cie𝗂𝗽. 𝗙cie𝗂𝗽. What is happening in the 𝗙cie𝗂𝗽? Now you tell me. So basically, this is the question of the general pathology here. Systemic pathology, but I'm asking you related to physiology. What can be the reason for 𝗙cie𝗂𝗽? Now you tell me there are two plexus in GIT. One is called as the � plexus. One is called a � plexus. One is called as Meissner's plexus. Meissner's plexus. Which plexus is absent in esophagus? Meissner's plexus is absent. � plexus is there. Please understand that � plexus is responsible for the peristaltic movement. Meissner's plexus is responsible for the secretions, right? So when Meissner's plexus is absent in esophagus, do you think there will be secretion in esophagus? Secretions are also absent in esophagus. Okay, there are four layers. Okay, mucosa, submucosa, muscularis propria, and serosa. Out of these four layers, which layer is absent in esophagus? Serosa is absent. So now you tell me, see here, what is happening in 𝗙cie𝗂𝗽? 𝗙cie𝗂𝗃, this is a type of motility disorder. This is a type of motility disorder where there will be neurogenic degeneration. There will be degeneration of nerves. So when I talk about nerves, only 𝗖𝗵 plexus is there, no? So there will be neurogenic degeneration of 𝗖𝗵 plexus. So now what is happening? So what is happening in the 𝗙cie 𝗂𝗃𝗃? Please understand that. See, there will be selective loss of inhibitory neurons. But stimulatory neurons are normal. Remember it. Stimulatory normals are normal. What is happening here? See, there will be stimulation. There will be the contraction, but there will be failure of relaxation. So there will not be normal lower esophageal sphincter relaxation. So this is a case of 𝗙cie 𝗂𝗃𝗃. 𝗙cie 𝗂𝗃𝗃, which you would have learned in your pathology also, medicine GIT also, and specifically in surgery. Right? So what is the surgery of choice? See, overall, what is the treatment of choice for 𝗙cie 𝗂𝗃𝗃? Can you tell me? See, we have learned there, no? See, 𝗙cie 𝗂𝗃𝗃. So finally, last surgery, we have to do what? 𝗙𝗪's cardiomyotomy. 𝗙𝗪's cardiomyotomy. If they are going to ask you, what is the name of surgery? 𝗙𝗪's cardiomyotomy. But what is the final what is the complete management of 𝗙𝗪's cardiomyotomy? Please understand that if you are going to remove the lower part of lower part of the esophagus, see, there can be hypersecretion of the hydrochloric acid also, and this can go up easily also because we have to maintain the normal pressure there, no? So for this, to stop the acid flow into the esophagus, we have to perform one more surgery that is called as Nissen's fundoplication. Nissen's fundoplication. 𝗙𝗪's cardiomyotomy. Along with that, we have to perform what? Fundoplication. We have to wrap the fundus part of the stomach around the lower part of esophagus so that we can maintain the pressure there and so that there should not be reflux into the esophagus. So Nissen's fundoplication, this is a type of what? Anti-reflux surgery, right? Anti-reflux surgery. Now the question is that 𝗙𝗪cie 𝗂𝗃𝗃, for sure. See, 𝗙𝗪cie 𝗂𝗃𝗃 also there can be what? So this is also a type of the like in future it can cause the development of cancer. Now the question is, 𝗙𝗪cie 𝗂𝗃𝗃 give rise to which type of cancer in future? Squamous cell carcinoma or adenocarcinoma? We have learned about Barrett's esophagus. We have learned about Barrett's esophagus. It will give rise to mostly adenocarcinoma. Adeno. What about 𝗙𝗪cie 𝗂𝗃𝗃? Mostly squamous cell carcinoma. Sometimes adeno also, but mostly squamous. These two are repeatedly asked questions, frequently asked questions. So we can say that Barrett esophagus as well as 𝗙𝗪cie 𝗂𝗃𝗃, these two are actually the pre-malignant lesions. See, now the question is, during the surgery of thyroid tumor of a patient, a small yellow gland got incised accidentally. Afterwards, patient is complaining of having tingling sensation, twitching in hands, feet, and face. So basically, see here, now you tell me, see, suppose if you were operating near the thyroid gland, yes, accidentally one yellow gland, which is actually a parathyroid gland, As we all know that it secretes a hormone that is called as the parathormone, which maintains calcium hemostasis in our body, calcium hemostasis. So whenever there will be removal of parathyroid gland, there will be what? Hypocalcemia. See, because patient is having symptoms like, see, symptoms like spasm, symptoms like the tetany, fine, because of what? Decreased level of calcium, because of hypocalcemia. All these are symptoms of hypocalcemia. So because of the removal of the parathyroid gland, there will be decreased level of what? Serum calcium, right? Fine. Now you tell me, see, there are the two signs which we are learning in hypocalcemia. First of all, if you are going to tap over the facial nerve part here, if you are going to tap here, there will be twitching of lips like this. This is called the Chopstick sign. Okay, fine. And if you are going to apply BP cough here, whenever you are going to increase the pressure, and if there will be flexion of wrist like this is called as the Roche's sign. Easy to understand? These two signs are seen in hypocalcemia. Repeatedly asked question. This can be your clinical question also, or this can be your one-liner question also. These two indicate what? These two indicate hypocalcemia. But there is one more important thing here. Okay, one is called as Roche's sign, which we have learned just now. One more sign is there, similar pronunciation, but spelling is different. Roche's sign. Where do we see this sign? Whenever there will be GI malignancy, or you can say stomach cancer, like if there will be gastric carcinoma, via thoracic duct, malignant cells can get deposited here over the left side over here, supraclavicular enlargement here, supraclavicular enlargement. This is called as Roche's sign. This can be one-liner question. This can be image-based question. Where do you see? You see in GI malignancy, or you can see in stomach carcinoma, stomach cancer. Where do you see this one? You are going to see flexion of wrist in hypocalcemia. One is hypocalcemia. Second is a type of where you can see in the carcinoma or in GI cancer. Now the question is that when accidentally, even if the parathyroid gland got removed, are you going to throw it? Are you going to throw it? No. You are going to do auto transplantation. You are going to keep it back. Now the question is that at which places you are going to keep it back? See here. Accidentally, see, during the thyroidectomy, if accidental removal happened, accidental removal, then you are going to place at sternocleidomastoid muscle. You are going to re-implant it under the sternocleidomastoid muscle. But if there was the case of parathyroid hyperplasia, parathyroid hyperplasia, where you have to perform the parathyroidectomy, where you are going to keep it again, you are going to keep under the brachioradialis muscle of non-dominant arm. These two are repeatedly asked questions. After the removal of parathyroid gland, at which place you are going to re-implant it? Either a sternocleidomastoid muscle or brachioradialis muscle. Next, a 60-year-old COVID-19 positive patient is admitted in hospital. He is agitated. He talks absurd. He is mentally confused. On general examination, temperature is 99.5. Blood pressure 102/80. SpO2 92%. Fine. His recent ABG report shows pH is 7.3, partial pressure of carbon dioxide 41, oxygen 85, potassium is 4, sodium is 118. Sodium is 118. Glucose is 110. Sodium is 118. Glucose is 110. Which of the following parameters is responsible for his condition? High fever, high potassium, high blood pressure or low blood pressure, high or low sodium? Very easy question now. No, very easy question for you. I see even the normal range. Okay, fine. 99. Okay, this is not very high, not very high. I would say BP, manageable. SpO2, 92%, see 90 to 94%, manageable. pH is, see here, pH is 7.3, normal. CO2, 41, normal. O2, oxygen, 80 to 100, Normal. 85 is completely normal. Potassium, what is the normal level of potassium? Can you answer me? Normal level of potassium is 3.5 to 5.5 milliequivalent per liter. What is the normal level of sodium? Can you answer me? 135 to 145. 135 to 145 milliequivalent per liter. See here, even potassium is also normal. What about sodium? Sodium is only 118. Even the glucose is also in the normal. No, glucose is a 110 is fine. Okay, fine. No. But sodium is a 110. Sodium is 118 here. Fine. No. So this patient is suffering from what? Patient is suffering from hyponatremia. This is a case of hyponatremia. Please understand that sodium is related to brain, potassium is related to heart. Okay, if there will be hypokalemia or hyperkalemia, there will be what? Arrhythmia. Fine. No? Sodium, hyponatremia, yes, there will be what? Mental confusion, agitation. Patient will be having different, okay, patient will be disoriented. So patient is having all these symptoms because of hyponatremia. Hyponatremia, answer will be D only, right? Fine. So what will be the symptoms of hyponatremia? Headache will be there, nausea, vomiting, sea fatigue, dizziness, mental confusion. Patient can go into coma also. How to treat? How to treat? You have to give hypertonic saline. Hypertonic saline. Okay, no? Like 1.5% or 3% or 5% of sodium chloride, right? Hypertonic saline, but it should be very, very slow infusion. Slow infusion. Slow infusion. You ask the nurse that I have to start my patient on hypertonic saline. You have to give slow infusion. But okay, this is a nighttime and nurse also wants to sleep. She's going to give fast infusion. Fast infusion. So if there will be fast infusion of hypertonic saline, what it can do? Demyelination, osmotic demyelination syndrome, osmotic demyelination syndrome. There will be dysphagia, dysarthria, right? No, fine. No, patient can have seizure and all. So where actually the pontine part will be affected. Fine. So overcorrection or the fast correction of hyponatremia can cause what? Osmotic demyelination syndrome, where pontine will also be affected. So do understand there should be what? Slow infusion of hypertonic saline. 35-year-old unmarried female complains of lack of energy, lack of appetite, insomnia, feeling of guilt for last 1 month. She gives the history of weight loss. She gives the history of weight loss. Her thyroid profile and ACTH stimulation tests are completely normal. Clinician wants to assess her neurotransmitter level. Which of the following can be cause for her condition? First of all, you diagnose the case, please. Diagnose the case, please. Obviously, like she is suffering from depression. Depression can also be seen in hypothyroidism or hyperthyroidism. Whenever there will be hypersecretion of the steroid, there can be depression. Fine. So like this patient has normal thyroid profile and ACTH stimulation test. Fine. So now basically this is the case of depression. Depression, lack of energy, lack of appetite, insomnia, feeling of guilt for last 1 month. Right now? Fine. So what will be the right answer here? Means basically I'm asking you, what is the reason, what is the root cause for depression? What we have learned, please understand here that which structure is responsible for the emotion? Limbic system, right? Limbic system. Limbic system. Limbic system generates the emotion. And frontal lobe regulates the emotion. I can say limbic system is the factory house and the frontal lobe, this is the motherboard. Okay, fine. So whenever, do understand that whenever there will be increased level of serotonin, dopamine and norepinephrine in limbic system, there will be what? Psychosis. Whenever there will be decreased level of serotonin, norepinephrine and dopamine, there will be what? Depression. Easy to understand. So out of these, right answer will be what? Decreased level of serotonin. Decreased level of serotonin. Fine. Now understand some more points related to dopamine. See, dopamine is also, this is also known as neurotransmitter for the kick. Right? So this is released from source of dopamine is substantia nigra. Okay, so this is dopamine is known as the neurotransmitter for the kick. For the kick, whenever a person is abusing any substance, okay, there will be release of what? Dopamine, and after that he will be getting the kick. Fine. Serotonin is known as happy hormone. Happy hormone. See, serotonin is responsible for good mood, good food, and good sleep. So whenever there will be lack of serotonin, decrease of serotonin, there will be sadness, anorexia, lack of appetite, insomnia. So that's why we have to increase what? Serotonin level, 𝗬𝗲𝗃, selective serotonin reuptake inhibitor. Whenever we are going to increase the serotonin level, then there will be improvement in mood, improvement in food, improvement in sleep. So that's why 𝗬𝗲𝗃 right now, this is the drug of choice for depression. Right. Now, norepinephrine. Norepinephrine, this is known as a hormone. This is known as neurotransmitter for energy and alertness. Energy and alert. Okay, fine. So when a person is having lack of norepinephrine, okay, lack of norepinephrine, he will be having lack of energy, no attention, no concentration, lack of energy. So that's why we are also giving what? SNRI, serotonin norepinephrine reuptake inhibitor, so that it will increase serotonin as well as norepinephrine. Now this can easily treat depression also. SNRI is also given for depression, no? Right? Okay, fine. So serotonin and norepinephrine, okay, now these together are called as happy hormone and the energy hormone. Happy and energy. Okay. Acetylcholine, this is responsible for what? Attention hormone. Whenever a person is going to smoke, when a person is going to smoke, cigarette smoking, okay, now cigarette smoking. So what do you have like in cigarette? Tobacco. There will be what? Nicotine. Okay, no? Now see here, nicotine is going to stimulate dopamine. This is going to stimulate choline receptor. Because of the stimulation of dopamine, a person will get the kick. Fine. Because of the stimulation of the choline, there will be what? Acetylcholine. So now after smoking a cigarette, a person will be having so much full of attention, full of concentration. He will be having good judgment power, good judgment power and all. Right now, he will be having good reasoning power, good mathematical calculation. Easy to understand. Fine. So acetylcholine. So this is a neurotransmitter for what? Attention. I hope this is clear to all of you. See, on the basis of these four neurotransmitters physiology, you can solve so many questions. Fine now. A 40-year-old female is complaining of tingling sensation over the arm. She was watching TV for long hours with hands under the head like this. Which type of nerve fiber is most likely to be affected, which you have learned in your basic physiology of nerve? Basically, due to pressure. Now you tell me which nerve fibers are most susceptible of pressure? A, B, C, A fiber, B fiber, or C fiber? A fiber, right? A, right? A. Okay, see. And related to hypoxia, BAC, local anesthesia, ABC. Okay, chalo, fine. Now, when I talk about A fiber, B fiber, and C fiber, let's discuss some more points here. Now you tell me, out of ABC, which one is having the maximum conduction velocity? Which one is having the maximum conduction velocity? A is having maximum conduction velocity. Which one is having? Okay, see why it is having the maximum conduction velocity, because it is thick and this is highly myelinated. Which is non-myelinated? C is non-myelinated. Which is the non-myelinated? C fiber. So this will be slowest conduction. Fine. Now, out of ABC, which carry fast pain, which carries, right, slow pain? A, fast pain, which is also called as epicritic, or the first pain. C, slow. A delta fiber, right? A delta fiber. Next, a 65-year-old female patient has dementia. There is a progressive impairment of cognitive function like okay, fine. See, like amnesia, aphasia, apraxia, and agnosia. There can be involvement of which of the following structure of the brain? See here, when I talk about dementia, right now, so there can be the involvement of cerebral cortex. There can be involvement of the cerebellum. Cerebellum also, basal ganglia also. Okay, fine. So what is happening here? See here, when I talk about cerebral cortex, if there will be any problem in the cortex, no, obviously a person will be having 4A's symptoms like amnesia, lack of memory, aphasia, lack of words, apraxia, lack of learned action, agnosia, where a person is not able to recognize something. So it means, so in this condition, patient is having 4A's symptoms. So there will be a problem in cerebral cortex. But what about cerebellum? Cerebellum is responsible for, and a cerebellum is responsible for what? Coordination in movements, right now? So if there will be a problem in cerebellum, there will be, okay, no? So see, after jumping, how to land on the ground normally. This is the normal function of cerebellum. If there will be a problem in the cerebellum, there will be problem in motor coordination. So in this condition, cerebral cortex. Fine now. So see, amnesia, aphasia, you see in Alzheimer type of dementia, right? Alzheimer dementia. But motor problem, movement problem like Huntington's, chorea and all, and Parkinson's, subcortical dementia. Fine? Subcortical dementia. Either there will be cortical dementia, cerebellum, basal ganglia, and brainstem nuclei. These are what? Subcortical structure. Subcortical dementia, motor problem. Next question. A 23-year-old unmarried female gets delusion and hallucination. Haloperidol is given to her. After that, she's complaining of galactorrhea. So basically, this is a question related to physiology, medicine, and psychiatry. Fine. Now let's understand this topic. See here. See, there are 4 dopaminergic tracts. One is called the mesolimbic tract. Second is called a mesocortical tract. Third is nigrostriatal pathway. Fourth is called the tuburoinfundibulum pathway. Mesolimbic, mesocortical, nigrostriatal, tuburoinfundibulum. There are 4 dopaminergic tracts in our brain. Fine. See here, in the beginning, See, in the beginning, like scientists were thinking that psychotic symptoms like delusion and hallucination. Delusion and hallucination. This was only because of dopamine. All these are seen in schizophrenia case. Fine. So if a person is normal, dopamine level in mesolimbic tract will be normal, mesocortical tract normal, nigrostriatal normal, in tiburo-infundibulum it will be normal. But there are two types of symptoms which we are seeing in schizophrenia patient. There are two types of symptoms. First of all, please understand, one is called as the positive symptoms, second is called as negative symptoms. If a schizophrenia patient is having delusion and hallucination, these are called as positive symptoms. Why these are called as positive symptoms? Because they have good prognosis, Negative symptoms like anhedonia, 𝗶𝗵, aphasia, asociality. These are called as negative symptoms because they have bad prognosis. Now the question is, when there will be development of positive symptoms, when there will be development of negative symptoms? Increased level of dopamine in mesolimbic tract will cause positive symptoms, and decreased level of dopamine in mesocortical tract will give rise to negative symptoms. Increased dopamine in mesolimbic, positive symptoms. Decreased dopamine in the mesocortical tract, negative symptoms. So now if you have a patient of schizophrenia, in mesolimbic tract, dopamine will be increased. In mesocortical tract, dopamine will be decreased. Here, normal, here, normal. Fine. In the beginning, when scientists were thinking that only dopamine is the main problem, so they developed one drug, and that was typically blocking D2 receptor. So that's why it was called as typical antipsychotic or first generation drug like haloperidol. But do you understand here that, see, this was completely blocking dopamine antagonist. So now you tell me, when I have given dopamine to my patient in mesolimbic tract, okay, fine, here it is going to decrease. So I can say that delusion and hallucination will be improved, normal. But what will happen to mesocortical tract? Here there will be further decrease of dopamine. Now there will be more negative symptoms, right? What about nigrostriatal pathway, which is responsible for movements, motor movements, right? Now, when I have given haloperidol, no, first generation drug, now there will be decrease of dopamine in nigrostriatal pathway also. Now patient is having restlessness, acute akathisia, acute dystonia, extrapyramidal symptom. Tiburo-infundibulum, there is a decrease of dopamine. As we all know that in tiburo-infundibulum we have one more hormone here that is called as the prolactin. And as we all know that dopamine and prolactin are antagonists of each other. If dopamine will increase, the prolactin will decrease. If dopamine will decrease, prolactin will increase. So now you tell me, when dopamine has decreased here, what will happen to prolactin? This will increase for sure. There will be hyperprolactinemia. Now you tell me oxytocin and prolactin, where you have learned related to galactorrhea, milk ejection, milk secretion, right? Now patient is complaining of galactorrhea. Patient is complaining of galactorrhea, lack of libido, gynecomastia. That is why, that is because of increased level of prolactin. Prolactin in which pathway, in which dopaminergic tract? In tiburo-infundibulum tract, right? Now you tell me, patient is complaining of galactorrhea, galactorrhea. So decrease of dopamine in which tract? Tiburo-infundibulum tract. Tiburo-infundibulum tract. Mesolimbic is responsible for the positive symptoms, mesocortical for the negative symptoms, nigrostriatal, this is for the extrapyramidal symptom because of the motor movements, right? Next, biochemistry question here. See, some tests are shown for protein, sugar, and ketone. Which of the following will be positive in starvation state in urine? When I talk about starvation, now you tell me, see what is happening here. Usually your body, see, starvation means what? What is happening here? If there is, see, if there is no glucose in your body, if there is no glucose in your body, okay, your body is going to burn the fats so that it can produce what? It can produce what? So that, like, after that there will be what? Fatty acid oxidation, and after that there will be fatty acid oxidation, and after that there will be formation of what? Ketone. Fine, no? Fine. See here, situation like starvation or diabetes. Okay, diabetes type 1. What is happening here? Whenever there will be, see, whenever there will be more fatty acid oxidation, this is going to provide more acetyl-CoA, which is actually the precursor for ketogenesis. After that, there will be a formation of what? Ketone bodies. Why no? Ketone bodies will be produced in liver itself, right? No? Fine. So like this is going to, so whenever there will be need, even the ketone bodies are used by some other structure, like some other organs like heart, muscle, and the renal cortex. Fine. But brain will use it only in a case of starvation. Fuel for the brain during starvation is what? Ketone bodies. Okay, fine. Easy to understand. See, what I have taught you that liver is the main factory house of ketone bodies, but liver does not use it. Why? Because of what? Anthony, please. Yeah, this is the question related to your biochemistry. Because liver has the absence of one enzyme which is known as CoA transferase, which is required for the activation of ketone body. So liver cannot use ketone bodies for the source of energy because it has absence of one enzyme, which is used for what? Activation of ketone bodies. Okay, fine. So now you tell me, so whenever there will be more fatty acid oxidation, like a starvation or the diabetes type 1, there will be more formation of acetyl-CoA, and after that there will be more formation of ketone bodies. Okay, fine. Chalo. See here, I have taught you that ketone bodies are mostly seen in starvation or the diabetes type 1. This will also be seen in, okay, so more ketosis will also be seen in alcoholism, or if there will be overdose of methanol or the salicylate, right? Salicylate. Or even during the pregnancy, if there will be, okay, no? Even during the pregnancy when there will be the toxemia. All right. Now the condition is, see, now you tell me, since I'm talking about starvation, some people who are on who are sitting on the hunger strike, like politicians and all. Okay, so like one doctor will go there, and now how doctor is going to understand that whether the person who is on hunger strike, he is in danger zone or not. Always remember that. What is happening here, when there is no glucose available in the body in a case of starvation, right now, fine. After that, body is going to burn the fat. There will be more fatty acid oxidation, and there will be production of ketone bodies. There will be ketone in blood, and that's why in urine also, blood and urine. So if you can find out ketone in urine, you can understand that patient or the person is in danger zone. How we are going to perform? Yes, we have some tests like Rothra's test and all, right? Rothra's test. Fine. Say here, one is in the purple color. One is having, say here, like the brown ring formation. One is red. These are repeatedly asked questions. So basically, see, when I talk about a starvation, there will be what? There will be increased level of ketone bodies. Out of these, which are the test for ketone? Find out which are the test for ketone bodies. See here, when I see this part, I'm going to explain you about this part here. Please understand that. See, one is called as the Rothra's test. One is called as Rothra's test. Rothra's test. What does it mean? See here, whenever ketone bodies are going to mix with alkaline solution of the sodium nitroprusside, there will be formation of a purple colored ring. Fine. Out of these two, see, this one is actually, so this is actually what? Rothra's test. See, the purple, this is for the protein, right? A protein. Fine. Okay, fine. Okay. So always remember Rothra's test and the Gerhardt test. This we are using for what? Ketone bodies. So first is a biuret test, that is for the protein, and last one, this is for what? Sugar, no? This is the red. This is for the Benedict's test, right? Okay, now find out the correct match in the relative changes in metabolic parameters during the onset of a starvation. See, a starvation is an important topic. You should understand it. What we have learned that yes, there will be increase of starvation. There will be increase of fatty acid at a certain level. Fine. But there will be maximum increase of ketone bodies. What about glucose? Obviously, it will fall. Out of all these, now you tell me which one is the right? See, a starvation, there will be what? Increased level of ketone bodies. See, when I talk about picture number 2, yes, there is actually a falling of this parameter, no? So this is actually what? Glucose. And what a picture number 1 here? See here, 1, somewhat elevation up to a certain level, fatty acid. Next question. In spite of taking fat-free, carbohydrate-rich diet, a person continues to grow obese. Which of the following lipoprotein is likely to be elevated in his blood? First of all, you tell me what is the function of chylomicrons and VLDL. See, this is going to carry exogenous lipids, not exogenous, right? See, this is going to take exogenous fat into the, and see here, chylomicrons are going to carry exogenous triglycerides, and after that, this will take to adipose tissue. Okay, fine. Since he is taking fat-free diet, so this will be decreased for sure. This will be decreased for sure. So now, so it means what? Now there is some kind of endogenous production. Endogenous. Now there is what? Since he is getting obese now. So now what is happening? There will be what? Endogenous production of triglycerides. And after that, like these are going to get accumulated in adipose tissue, whose function is this to carry endogenous triglyceride to adipose tissue, VLDL, VLDL. And that's why a person is getting what? Obese, right now. So in this patient, VLDL will be increased. VLDL will be increased. Now, what is the function of LDL? What is the function of HDL? Answer me, please. LDL and HDL. See here, what does LDL do? LDL. It is going to take cholesterol from liver to peripheral tissues, peripheral tissues. So what is happening here? If there is higher concentration, see, if there is higher concentration of LDL, then do understand that then there will be more and more deposition of cholesterol in the peripheral tissues, which will lead to the formation of what? Atherosclerosis. And finally, in future, it can lead to myocardial infarction. That's why LDL is called as bad cholesterol, right? A bad lipoprotein, no? Bad. What about HDL? HDL is called as a good lipoprotein, right? Good. Finally, so what is happening and what it does? It is going to remove. Free cholesterol from extrahepatic tissues. So basically this acts like a scavenger. So that's why HDL is considered as good cholesterol. What about this one? A patient presented with complaints of some abnormal deposits in eyes and ear as shown below. Suspecting a metabolic disorder, clinician did his X-ray, spine, and urine analysis. Findings are shown below. Which enzyme deficiency? First of all, you see here, this is a type of what? Metabolic disorder. Okay, fine. You can see urine becomes black. Okay. And you can see there is blackish deposition over ear, over sclera, and even in intervertebral disc also. Please understand that there is a metabolic disorder. Whenever there will be deficiency of homogentisate oxidase. See, now I hope you have understood what is the diagnosis here? This is phenylketonuria or alkaptonuria. What is your answer? Please answer me. बोल दो. Obviously alkaptonuria, no? So whenever there will be deficiency of this enzyme, there will be more excretion of homogentisic acid. Right? Okay, fine. Now understand here that. See here, whenever there will be more production of whenever there will be more excretion of homogentisic acid, when it is going to get exposed to air, see, there will be oxidation. And homogentisate will be converted into benzoquinone acetate. And after that, this will polymers to become what? Black color pigment, which is called as alkapton. And So what is happening here? Please understand that. So see this black or the brownish color, this is somewhat like 𝗏𝗏𝗏. So what is happening here? See, there can be deposition of the 𝗏𝗏𝗏 in the ear part, eye part, sclera, and even in the intervertebral disc also. So this is seen where? This is seen in 𝗏𝗏𝗏𝗏, 𝗏𝗏𝗏𝗏, right? 𝗏𝗏𝗏𝗏. Fine, see here, sometimes if they are going to ask you one-liner question related to the enzyme deficiency and diseases, all they see phenylalanine hydroxylase, in which disease you see the deficiency of this enzyme, okay? So all these you have to memorize. See, what about phenylketonuria? See, whenever there will be deficiency of what? Phenylalanine hydroxylase, right? There you are going to see the mousy odor in urine. You have to memorize all these enzyme deficiency. Next. A 45-year-old man presents to a clinic with complaints of weight loss, frequent urination, increased thirst and appetite. His father had similar symptoms who was on metformin for last 7 years. Now, clinician is also suspecting diabetes, right? So he wants to check his sugar level. Lab technician has collected this sample in given tube. Which tube? Gray color tube, right? Or gray color tube. This sample tube has one agent that ensures that further breakdown of glucose will not happen, so that accurate level of glucose can be estimated. Which of the following is the right statement related to this scenario? See here, whenever you are going to collect the blood sample during your internship, you will be having different blood sample collection tubes. See here, you can see like this is gray color. So there can be a red color, there can be a purple color. What is the significance of this gray color tube? What is happening here? See here, we are going to apply here the biochemistry of glycolysis. Glycolysis means glucose will be break down into the pyruvate, right? After the glycolysis, right? After the aerobic glycolysis. What is happening here? If there will be complete breakdown of glucose, lab technician came to your clinic at 9 a.m. He collected the sample, but he reached his diagnostic center at 10 a.m. So don't you think, had you collected this blood sample in a plain tube, after 1 hour, there could have been further degradation of the glucose, right now? So you could not measure the exact level of sugar in the blood. Now, in this tube, we have added one thing. We have added actually 2 elements here. First of all, there should not be clotting of blood. Okay, fine. Second, there should not be conversion of glucose into pyruvate. We have added sodium fluoride. I hope you remember the second and last step of glycolysis, where enolase enzyme is going to work. Fluoride can inhibit. If fluoride can inhibit enolase enzyme, then there will not be complete breakdown of glucose. So we are adding 2 things. One is, see here, sodium fluoride. So we have added what? Sodium fluoride, which is going to block enolase enzyme. Potassium oxalate is also there, which is actually anticoagulant. So in this question, option number C is right. See, different tubes. See, a red color when you have to measure, like LFT, KFT, right? And the purple color, CBC, and right, CBC, okay, blood grouping and all. Gray color, sugar. Black, ESR. Okay, sky blue color, this is for sky blue. This is for the clotting profile, right? Clotting profile like bleeding time, BT, and the PT-INR. Green color, heparin. Yellow color for blood culture. These all are old questions only. A 9-year girl is presented to your clinic with complaints of acute abdominal pain on and off with tingling sensation of limbs. Her mother is informing that she used to be fond of eating paint from the wall of newly built house. Which enzyme deficiency can cause these symptoms? So here, like examiner has framed the question related to psychiatry and medicine. See here, appetite for a non-nutritive substances is called as 𝗙𝗃. Like, you know, like eating the brick and the chalk, right? Eating the clay earth. Here, this 9-year-old girl, she loves to lick the new wall paint. Okay. What is there in the new wall paint? There will be lead. Why lead is added in new wall paint? Why lead is added? So that it can increase the durability, or like this will appear to be more fresh. Fine. I hope you know that lead is blocking. Lead is bad for heme metabolism. Heme metabolism. If there will be lead poisoning, lead toxicity during the heme metabolism, which enzymes it is going to block? ALA dehydratase and ferrochelatase. Fine. So what is happening here? See here. So there will be problem in the what? Heme metabolism. See whatever. So what is happening here? Here patient is having, see here, no? Like abdominal pain. So like all these are the signs and symptoms of what? Lead poisoning, which is blocking what? ALA dehydratase. ALA dehydratase, right? ALA dehydratase. A case of short bowel syndrome due to terminal ileum resection. Difficulty in breathing, fatigue, diarrhea, nausea, and loss of appetite. On further examination, patient is having glossitis and tingling sensation in the limb. Deficiency of which vitamin or which of the minerals can cause the symptoms? So like patient was suffering from a disease where there was a resection of intestine. First of all, now tell me, how much is the length of a small intestine? 600 centimeter. 6 meter. Whenever there will be less than 200 centimeter of intestine, it will lead to what? Short bowel syndrome. Fine. No? See the terminal ileum. See, this is the ascending colon and this is the terminal ileum. Right? This is the terminal ileum. What is the function of the terminal ileum? Reabsorption of vitamin B12. Reabsorption of vitamin B12 and enterohepatic circulation of bile juice. So this patient can have what? Deficiency of vitamin B12. Vitamin B12. Fine now? Easy to understand? Vitamin B12. So basically she's suffering from what? Megaloblastic anemia. Related to vitamin B12, last time also they have asked the question. See, last time in December exam, they have asked, I think 4 or 5 questions only on vitamins, right? So you have to be very, very careful. Okay, see here, please understand and memorize all the things related to vitamin A, B1, B2, like riboflavin and all, fine, no? And after that, C, scurvy, and D, obviously, right? And vitamin B12. All these are very, very important, and even related to pyridoxine, right? A 46-year-old lady presented with bony pain, okay? Hepatosplenomegaly is found. On examination of biopsy specimen from spleen, a special type of tissue appearance is seen, rumpled tissue appearance. Where we have seen, you might have learned in your biochemistry that hepatosplenomegaly with bony pain, this is something related to Gaucher's disease, right? Gaucher's disease, fine. No? Whenever you do biopsy, you will see this type of appearance. See here, this type of appearance, right? So this is what? This type of appearance, this is called as crumpled tissue appearance, Gaucher's disease, fine. No? So now if I ask you which enzyme deficiency you are going to see there, there will be deficiency of glucocerebrosidase. And because of this, what is happening here? There will be accumulation of what? Glucocerebroside in brain. 𝗏𝗃𝐶𝑒𝑟𝑒𝑏𝑟ocyte in brain. Keratin is present in both skin and nail, but nail is harder than skin. What is the reason? Hardness due to a protein is because of disulfide bond. Disulfide bond. Disulfide bond. So increased number of disulfide bond. Final. More the disulfide bond, harder the protein. So do understand that this is the main reason for this. Next, an alcoholic malnourished patient present to emergency room with respiratory distress. His pulse rate is high. His pulse rate is high, pedal edema, hypertension, and systolic murmur, along with bilateral crepitation. A diagnosis of congestive high output cardiac heart failure is made. Which vitamin deficiency can cause this? First of all, first hint, alcoholic. Second, he is malnourished. See, in alcoholic patient, there will be deficiency of vitamin B1, which is called as the thiamine, First of all, what is the function of the thiamine? See here, your body needs vitamin B1 for the proper breakdown of food so that there should be proper metabolism first. Second function of thiamine. Muscles need thiamine. Nervous tissue needs thiamine so that they can work efficiently. So whenever there will be deficiency of thiamine, see here, muscles will be affected, CVS will be affected, nervous system will be affected. Nervous system will be affected. So that's why in this condition, patient is having what? See here, heart problem, congestive cardiac heart problem, like respiration problem also. So overall, this is because of what? Deficiency of thiamine, vitamin B1. So what is happening here? So please understand that even in alcoholic patient, okay, we have learned in psychiatry, we have learned in substance abuse, right? In severe alcoholism, whenever you are going to treat, first of all, you have to start with the benzodiazepine. And whenever a person is there for their de-addiction, whenever you have to stop it, right now. So first of all, you have to do what? Detoxification with the help of benzodiazepine like chlordiazepoxide. Along with this, we are also giving thiamine injection because there will be deficiency of thiamine. IV injection, how much you are giving? 250 milligram, at least for 7 to 14 days. After that, you have to keep your patient on oral thiamine at least for 90 days. Oral thiamine. So see here, so overall, as per the condition, clinical condition, we have understood that yes, there was a deficiency of vitamin B1. So vitamin B1 deficiency, this leads to what? A disease that is called what? Beriberi. Right now, all these signs and symptoms you are going to see in beriberi. Next question. A child presents with hyperuricemia, delayed developmental milestones. He also has the habit of biting fingers and nails. Whenever there will be metabolic disorder, whenever you are going to see self-mutilation, self-mutilation, where we can see self-mutilation, harming self. This is a type of purine metabolism deficient. This is the disorder of purine metabolism. Whenever there will be deficiency of 𝗏𝗄𝗏 enzyme. So what is happening there? So there will be more accumulation of the purine. There will be more accumulation of the purine, and after that, there will be more formation of what? Uric acid. Whenever there will be hyperuricemia, symptoms will be there like gouty, painful joints, and all. So this is also type of what? This is also type of purine metabolism disorder. This disorder is called as Lesch-Nyhan syndrome. Lesch-Nyhan syndrome. Which enzyme deficiency? HGPRTase. Last question here. In the test given below, to estimate blood glucose level, which of the following is right statement? Basically here, see, this is what? Assessment of what? Glucose. Glucometer, no? Glucometer test, right? Glucometer test. See here, which of the following is right statement? How to perform? See, this is very, very common. This is very, very common. See, this question was not there in your exam, but yes, I have like in my paper, it was there. So this is the last question which I'm going to discuss. Just learn it. Maybe this could be the question, because see, we are going to learn the mechanism of action of the glucometer, how glucometer is functioning. So please understand that. Please understand that. See, this is called, see this part, this is called as the strip, right now, strip. See here, in all strip, there is one enzyme that is called as glucose oxidase. In all strip, I'm talking about a strip. There is one enzyme that is called as glucose oxidase. Glucose oxidase. Fine. Now, this enzyme is going to react with the glucose. This enzyme is going to react with the glucose which is present in the blood sample. And now this is going to create gluconic acid. This is going to create what? Gluconic acid. Gluconic acid. Now see here, now this gluconic acid, it is going to react with another chemical which is also present in a strip, that is called as ferricyanide. That is called as ferricyanide. Ferricyanide. Fine. Now, ferricyanide and gluconic acid, these both are going to create ferrocyanide. Now, see this ferrocyanide. So now the device will run an electronic current through the blood sample. And now with the help of this electricity, what is happening here? Now with the help of this is going to read the ferrocyanide. This is going to read the ferrocyanide, and exactly it is going to read how much glucose is there in the blood sample and in the actually in this strip, right now over this strip, because of the blood sample, right? And this number will be displayed over the screen. Fine. So this is a type of glucose oxidase peroxidase method. See, first carbon will be, okay, first carbon is going to oxidize, not the last. Okay, no? Fine. So what is the right answer here? This is a type of glucose oxidase peroxidase method. In this way, we perform what? Like in this manner, we check actual method, like actual level of glucose. So I hope all these 75 clinical questions which I have completed, and yesterday 75 clinical questions got completed by Dr. Khalil sir, right now. So I hope in total 150 questions which we have discussed here, these are going to help you a lot. Please understand that what was the purpose behind this, so that you could understand what kind of clinical questions are being framed out of non-clinical subjects. Now, how much you have learned in your 4 months, now you have to do what? Now in last 1 month, the best method is to get indulged into the test and discussion, I'm telling you. And now you have to be very, very much careful whenever you are going to solve any question. Don't rely only on one-liner question. Now, what kind of question they're framing here? Please understand that out of 300, approximately 150 to 180 questions will be clinically oriented, clinical based question. 40 to 50 questions will be image based questions, and hardly 70 to 90 you can anticipate one-liner question. Hardly 70 to 90. Fine. So in the last 1 month, however you have learned so far, see, like you have been learning for last 4 months, no? You have been learning in a prospective manner. Now you have to learn in a retrospective manner. Now solve the question, and after that, as per the question, revise all the important points related to the same topic. Fine. Fine. So now you cannot revise all most important. See, now you cannot revise all the topics which we have completed so far. So now better is to revise most important topics. So last 1 month, you should practice more and more question. Okay, see, and you should revise more and more. Fine. So chalo then, I hope this is going to help you. I wish you all the best. And there will be Eid in the morning tomorrow. Like see, out of India, like in Russia and the Kyrgyzstan, Kazakhstan, everywhere you already have celebrated Eid. But in India, we are going to celebrate tomorrow. So I wish you all a very happy Eid. Eid Mubarak to all of you. Thank you so much. I wish you all the best for your exam on 4th June. Thank you so much. Okay, this PDF will be shared. Okay, like this PDF will be shared in the Arise group, Telegram group. Okay. Okay then, bye-bye. Good night.